Okay, so welcome to day 3. We've got an interesting and varied program this morning. Just because the next slide. So unfortunately, this is not happening. Apparently the truck broke down, or so we're told, on the way from New York. So you'll have to continue with the coffee that's provided. But I'm sure that won't happen in Italy. So the session highlights for this morning, we've got the Shark Tank shark event, which is really, it's later, yeah.
First is fatigue.
Okay, but I'm just, I'm mixing it up a bit. But we have got fatigue, which none of us are experiencing this morning, and that's great. And then an AI session, so 3 really interesting sessions.
Gil tells me AI section slides are not all here yet. Yeah. Which I assume, I don't see the speakers here either, so I guess they're in their rooms doing their slides. So.
Yeah, okay, well hopefully they'll come. Yeah. Okay, next slide.
And wait, and we heard there's no breaks, Michael.
Yeah, the program this morning is a bit of a marathon, so we wanted you to experience fatigue. And obviously you can, as the meeting is going, you can get coffee continually, but there's no actual dedicated break, so we're going to just push on till... is it 12:30?
So, planning committee for Italy, just note to self, breaks.
Coffee and breaks, yeah. Yeah. Okay,
all right.
Do you want to do the next one?
The next one. Oh, that's right, you don't care about American CME, do you? No. Right, I don't think so. No. So for North Americans, you can get CME, which is an interesting thing. So Liz told me we only do it when we have our meetings in the U.S., and I'm not sure I understand that concept, because I think we can still give American CME if we're in Oxford or Italy. Okay. Well, I don't know that it's geographically based. It's whatever organ.
We can do
but
that
I could be wrong on that. Yeah, I could be wrong on that.
CME can't be done abroad, I don't think.
Well, so I'm wrong 50% of the time, so it's possible. Yeah. I'm wrong about that. So, but this year you can get CME, and that's your link. We want you to evaluate the meeting, including the social events, and print or download, save your certificates. Okay, and just to remind you that the journal is all online, so you can. I gave you that link the other day for your abstracts.
Okay.
Okay. What's next?
So then, obviously, just again. I think it's important just to thank the planning committee. Huge amount of work led by Michael. Really excellent program. So maybe just a round of
but no break.
But no break today. Yeah. But it has been excellent. So a round of applause maybe for all the work they've done.
Yeah. No, I agree. The planning committee did an amazing job this year. It's just perfect program. And Valeria and the planning committee for next year, we had lunch yesterday, and it's going to be pretty cool next year in Italy. The program's going to be great, and the location will be great. Yeah. Okay, what's next, Michael? Oh,
so there it is.
So the Italy's on your right, and so we're going back to Stresa next year. Yeah. So there may be a few of you who didn't make it to Italy a couple years ago. It is really magical. So that's going to be wonderful. And then on the left, for Dr. Amato and others who have San Antonio ties, you'll recognize this building. So this is the old Menger Hotel in downtown San Antonio. It's directly next to the Alamo, which I think the next picture will show. Oh, yeah, and the Battle of the Alamo, right. So you can't see it, obviously, but the Menger and the Alamo are like 50 feet apart. It's very cool. So if any of you have ever seen the great TV show from the 90s, Lonesome Dove, where Captain Gus and Captain McCall are in the Menger bar, and their picture is up behind the bartender, and the bartender's not giving him any respect, and Gus smashes his face into the bar, and it's a great scene. So it's all happened there. So I was I spent a lot of time in San Antonio, and I was there for something in the last 6 months, and I was staying downtown, and it occurred to me that this environment in downtown San Antonio while not secluded like Tarrytown, could be ideal for the NMSG meeting. There's all sorts of stuff to do downtown in walking distance, and then there's the Alamo. So I think that'll be really nice. It's not quite a done deal, but it's affordable and it's relatively easy to get to. So I think you'll have a good time there. And we don't know where we're going the year after. There's a lot of discussion.
Yeah, maybe back
maybe
to the UK.
Yeah. So, all right.
Yes.
Okay,
Yes?
good.
Oh, we are? Oh, it's a yes.
Okay, well, that's definite. I think James here was interested in helping to look at possible places in the UK, so we'll update you about that.
Was that it?
That's
Okay,
it.
that's
So we'll hand over to the first moderator.
Jackie Montez is going to talk about fatigue post social event.
Well, good morning. It's really a pleasure to be part of a session on fatigue and fatigability. I mean, this has been my passion for several years now, but from the past talks over the last 2 days, we can see that fatigue really plagues many of our patients of different conditions, and it's been a problem and somewhat difficult to understand and measure and treat. So hopefully, I anticipate we'll have some great discussions. And I'll start off the session by talking about what I think of as the unyielding characteristic of fatigability in SMA, and hope that we all think a bit beyond just weakness when we think about fatigability. So here are my disclosures. So we're in a wonderful position here in SMA to have 3 disease-modifying therapies that anyone born with or living with SMA is it's available to. And these figures represent the New England Journal of Medicine papers that highlight the improvements in function that we've seen in babies and children from the phase 3 studies. And since these publications, there have been several reports in broader cohorts in adults and children that highlight similar improvements in function. But there are still unmet needs. This survey was led by Cure SMA last year, and in addition to wanting improvements in strength and in function, nearly all the adults that they surveyed and more than half of the caregivers said that reducing fatigue was one of their most significant unmet needs. But fatigue is really complicated, and I think this has led to sort of confusion and difficulty in understanding the symptom as well as treating it. So back in 2013, Kluger et al. Published or proposed a taxonomy to better understand fatigue in neurological conditions, which would include neuromuscular conditions. And they proposed that there are 2 sort of main buckets. There's perceived or perceptions of fatigue, and the underlying factors that might be contributing to this could be homeostatic or psychological. And then there's performance fatigability, where the underlying factors may be peripheral or central. In this taxonomy, they provided definitions, and perceptions of fatigue or subjective fatigue is simply feelings of tiredness, and this can be mental, physical, or both. Whereas performance fatigability is the decline in one or more aspects of performance during a continuous or prolonged task. So what about assessments for fatigue? Well, this figure comes from a scoping review that was recently published, led by Ralph Rodriguez-Torres. And what I'd like to highlight is that fatigue is very multidimensional. And so fatigue could be made up of mental fatigue, motivational fatigue, cognitive fatigue, sleep-related fatigue, and there have been several scales that have been applied in SMA to capture some of these dimensions of the experience. Similarly, physical fatigue, which is different than performance fatigability, also there have been several different scales, both general scales and disease-specific scales that have been applied to better understand this experience in SMA with sort of limited results and interpretability. So what about fatigability? It's reasonable to think that since weakness is a symptom of many of our neuromuscular disorders, looking at force output and its impact on fatigability would be really informative. And more than 20 years ago, Mohammed Sanjak and colleagues proposed using maximum voluntary isometric contraction or force output to evaluate fatigability. And so in this figure on the right, this schematic highlights a force on the y-axis and time on the x, and what they proposed is that with a sustained contraction, that even in healthy people, the force output from a sustained contraction would decline, and that area above the curve would capture fatigability or the fatigue index. And again, I highlight that this is expected. The force that force output would decline even in you and me. And so when they applied this method to a cohort of ALS patients and they studied the elbow flexors and the ankle dorsiflexors, they found that that fatigue index was higher in the ALS patients when you compared it to controls. And it actually there was also a corresponding attenuated shift in the median power frequency curves. But when you looked at when it was applied to an SMA cohort back in the late 90s, Dr. Yannicone and colleagues used this same method in a large cohort of SMA children and found that, and studied several muscle groups, and despite that, there was no difference in this fatigue index in the SMA patients or the controls. So going back to the definition of fatigability, it's the decline, again, of one or more aspects of performance during a continuous or prolonged task. Endurance, on the other hand, is the ability of a sustained or prolonged effort or activity. And I propose that, sorry, I'm having clicker troubles. I propose that maybe we should think about them on a continuum, right? So endurance being on one end of the continuum, whereas fatigability on the other. And so that our group, the PNCR, thought, let's look at our core assessments and see if there's some assessment of performance fatigability that we can apply. And so the Hammersmith Functional Motor Scale Expanded is a robust assessment of motor function and has been used widely in SMA to evaluate treatment effectiveness. However, it doesn't require a repeated task and therefore wouldn't be a good assessment of fatigability. Similarly, the revised upper limb module is an upper limb assessment that doesn't require a repeated assessment and therefore wouldn't be a good assessment of fatigability. However, the 6-minute walk test, which is widely used in SMA management, is a continuous task, and so it could be an assay for fatigability. So our group decided to look at the 6-minute walk test, and in fact, we found that the velocity walked in the last minute, the 6-minute, compared to the first minute, was significantly different, that they slowed down at the end of the test, and that difference over the 6 minutes was about 17%. We then thought, to understand what was contributing to that change in velocity, so we put an instrumented walkway in the center of our 6-minute walk test course, and we found that it was stride length, not cadence, that was contributing to that change in velocity. And we saw it in SMA patients and not in healthy controls. So with that in mind, we thought, well, since the 6-minute walk test was used or is used as an assessment of walking ability in all our clinic patients, that and who have weakness. So maybe we wanted to see if it was informative in a diverse group of neuromuscular patients. And so when we looked at our 6-minute walk test, we found that only in SMA was there fatigability, and that fatigability was associated with a 6-minute walk test distance. And then when we looked at a cohort of Becker and Duchenne patients, as well as a broad group of energy failure patients largely with GLUT1 deficiency syndrome and myasthenia gravis, despite a range of distance walks on the 6-minute walk test representing weakness and strength, there was no discernible fatigability. But admittedly, the myasthenia group was puzzling to us because fatigability is the hallmark of myasthenia gravis, and we know the neuromuscular junction is implicated there. So we were wondering why there wasn't fatigability on this test in that group. And what we realized after thinking about it some more and looking back in charts is that only effectively treated children with myasthenia gravis were included in our original cohort and who completed the 6-minute walk test and then had no measurable fatigability. And I'd like to highlight 2 case examples of this. So there was an 8-year-old boy who presented to us with symptoms of myasthenia gravis with ptosis and weakness and complaints of fatigue. Was diagnosed with myasthenia gravis, started on mestinon and prednisone. At a follow-up appointment, we attempted the 6-minute walk test. He was unable to complete it and stopped because of subjective fatigue and gait decompensation. He was then sent for a thymectomy and continued mestinon treatment, and at a follow-up visit was able to complete the 6-minute walk test and with no measurable fatigability. Similarly, there's a patient that presented to us, 15-year-old girl with facial weakness, ptosis, and bulbar and fatigue and generalized weakness. She was diagnosed with malignant thymoma and myasthenia gravis. Upon evaluation, we attempted the 6-minute walk test, and she was similarly unable to complete it, secondary to fatigue. And she was then started on treatment for the thymoma, including radiation and chemotherapy, a thymectomy, and then medically managed, and then at a later follow-up appointment was able to complete the 6-minute walk test with no measurable fatigability. So, but not all SMA patients walk. So, but they do experience fatigability. And so these papers highlight the body of work that's been led by Bart Bartels in the Netherlands, looking at developing a battery of endurance shuttle tests for the upper limb. In the figure on the right, what you can see is that nearly 50% of the patients have dropout or fatigability. They have to stop the test at about 3.5 minutes during a 20-minute test. And this applied to both weaker and stronger patients. But in the weakest individuals with SMA, fatigability can affect essential functions like eating. And so there's work done by another Dutch group to develop the 6-minute mastication test. And in this, they evaluate masticatory cycles over the 6 minutes, and they found that the chewing cycles in the 6-minute was less than in the first minute, and that this was worse for weaker patients. But I'd like to remind you that, again, from the taxonomy that was proposed earlier, fatigue and fatigability have different underlying constructs, and they need to be considered separately. And in SMA, we found that they're not related. And so in work led by Sally Dunaway-Young, we looked at the association between perceived fatigue, so on the FSS and the PedsQL fatigue module, and compared it to fatigability on the 6-minute walk test and found no association. And then similarly, more recently, Bart Bartels' group used the PROMIS fatigue scale and found no association with the shuttle tests. And in fact, he saw that there was fatigability in both weak and strong patients. But as we started out, we're in the treatment era of SMA, and fatigue still remains a common and persistent problem. This was a US-based community survey, and what they found is that on the PROMIS scale, fatigue in SMA is greater than the general US population, and it's irrespective of function or type. And it's possible that fatigue might be, there's some evidence to suggest that fatigue is refractory to SMN-targeted therapies. And so this work here, led by Tim Hagenacker's group on the left, studied adults with SMA, both ambulatory and non-ambulatory, and found that fatigue after 10 months of treatment had sort of small effects. If anything, there was really no change in their fatigue. More recently, Cure SMA also led a survey of a large cohort of adults, 75% of whom were reported being on a disease-modifying therapy. And in that cohort, on all the fatigue scales that they applied, the SMA adults had greater fatigue than the general population. There is also a publication here from another German group who used the FSS, the total score, as well as item 8, which says fatigue is one of my most disabling symptoms, as well as a multidimensional fatigue scale. And what they found on all aspects of these scales, that fatigue wasn't better after 14 months of nusinersen treatment. So what about fatigability? Well, fatigability may also be refractory to SMN-targeted therapies. And so we looked at the children that were enrolled in the early phase studies of nusinersen, and while there were remarkable improvements in 6-minute walk test distance over 3 years, there was a blunted response in fatigability with little or no change. And just recently, there's a recently published article that had similar results in adults treated with nusinersen. And then when we use electrophysiological measures to understand response to treatment in SMA patients, in this work led by Dave Arnold, he showed that while CMAP amplitude improved with 14 months of nusinersen treatment in an adult cohort, the decrement in CMAP with repetitive nerve stimulation didn't. So what's next? Where are the gaps? I feel like we have a good set of assessments of fatigability, and we have a fairly good understanding about what the potential underlying causes are, whether it's the neuromuscular junction, or it's mitochondrial dysfunction, or the sensory motor circuit. But what's missing, in my opinion, is the link, right? To understand how the underlying pathophysiology is related to the patient experience and our observations. We can always expand our toolbox of assessments to better understand treatment effects and this experience. And there's efforts that Ralph Rodriguez is going to talk about to develop more patient-reported outcome measures. There's a wearable technology that Dr. Zana is going to talk about later today to assess fatigability in real-world environments. And there's work led by Tina Duong at Stanford to evaluate endurance in a non-ambulant population. And lastly, while the work that's largely been published now is focused on the impact of SMN-targeted, mostly nusinersen of the SMN-targeted therapies, but and probably because it was the first to be approved, but there are other therapies that we need to understand their impact on fatigability. There are muscle-targeted therapies in development that it would be important to understand their impact on fatigability. And exercise is known to mitigate the symptoms of fatigue in the healthy population, and exercise is a medicine that I think requires study and its impact on fatigability as well. And so with that, I will certainly take questions. I would love to acknowledge my colleagues, collaborators, mentors at Columbia University in the programs in physical therapy and the Department of Neurology and the Motor Neuron Center, my colleagues in the, and collaborators in the Pediatric Neuromuscular Clinical Research Network, you know, especially Mike McDermott for his mentorship and collaboration, Dr. Damiano Zanato, my engineer colleague, and all the funding that we've received over the years for several projects from QRSMA, MDA, NIH, and Neuromuscular Study Group, and an ongoing study that is supported by Genentech. So thank you. I'm happy to take questions. Chad?
Thank you for that talk. I really love that. And, you know, in studying disease burden in a whole bunch of populations, what we find over and over again is fatigue is one of the most devastating issues symptomatically for all the muscular dystrophies and the neuropathies and the motor neuropathies. So, and just, we've looked into this. So we developed the SMA-HI, as you know, and there's a disease-specific subscale specifically for fatigue in that population. And it's just something that I think want to consider moving forward because it's really good at detecting change in that particular area of disease burden. And we've seen that it responds to things like nusinersen in adults. And so it's really, I think, important. And the work you're doing it really needs to be applauded because we need to get a handle of this really devastating symptomatic issue. Thank you.
Yeah. Thank you, Chad. I agree that good measures of disease burden, the impact on the individual is really essential, and those could definitely be aligned with also measures that interrogate the underlying pathophysiology, or at least be related to the treatment that's being applied. So I agree. Thank you.
Thank you for a very interesting talk, Jackie. I also believe fatigue is very important for disease like SMA or disease like ALS. When we think about motor neuron degeneration, there is regeneration and reinnervation of the muscle fibers to motor neuron that's surviving. So when I saw that the amplitude improved after the SMA treatment, I was thinking, potentially the remaining motor neurons now reinnervating those denervated muscles. So that means the amplitude might be coming back to baseline. Probably there's still lower number of motor units. So if you do MUNI, the value will be lower than normal. I wonder if that's related with fatigue. So you're using the same force with reduced number of motor neurons might contribute to fatigue. Also, there's some immature neuromuscular junctions evidenced by the abnormal rapid nerve stem. So when your motor neuron junctions not normal, then obviously similar to neuromuscular junction disease like MG, I guess you can have fatigue. Another thing that I was thinking, maybe there's a type 1, type 2 fiber mismatch. A normal muscle has a certain portion of type 1 fibers that's more endurance than strength. But when the muscle goes through reconstruction, maybe those ratios might have been altered. So those are the things that came to my mind for fatigue.
No, thank you. Those are all great points. I don't believe that MUNI has been correlated with fatigability in any reports that I'm aware of, but I think what you're highlighting is that there are other electrophysiological assessments that may be very informative to speak to the underlying mechanisms about innervation and reinnervation. I think the earlier work that looks at the median power, median frequency shifts is probably also equally important. And lastly, you touch upon fiber type and that's sort of moving into the energetics and at the muscle level, and that's equally as important to, and could be related to mitochondrial function, or there's lots of work to be done better understand, and lots of tools to assess them. So thank you.
Hi, Jackie. Thank you so much for that talk. You have done a lot of work in the 6-minute walk test, and as you mentioned, there's been new endurance shuttle tests, including the endurance shuttle walk test. So I'm wondering if you can comment on how those two might be used moving forward, whether one might be better than the other, or what to consider when using either the 6-minute walk test or the endurance shuttle walk test.
Yeah, no, that's a good question. So yes, it's part of the battery of shuttle tests that Bartels has developed. One of them was an endurance shuttle walk test, and so admittedly, I mean, everybody probably would agree that I have a bias towards the 6-minute walk test. So I might be die on the knife of the 6-minute walk test. But I have limited experience on the shuttle test. I think the challenge with the shuttle walk test is that to develop the intensity, you have to do several iterations of 10-meter walks to get their fastest speed. Then to titrate that to have the intensity to be determined, then they have to walk and can walk up to 20 minutes. And therefore, my concerns with the endurance shuttle walk test is that the burden exceeds the benefit. And so for those reasons, I'm admitting that I'm biased to the 6-minute walk test, but for those reasons, I think that it has limited value. But maybe when if people are really improving and we really get to a ceiling, then maybe that they'll have some utility. That's my opinion, though. Valeria?
We have time for one more question.
Up here. Oh, sorry.
Thank you very much. Great talk, great question. Your anticipated wonderful discussion. Thank you. Regarding electrophysiological testing for fatigue, and I don't do this anymore, but I have an idea. I was reminded by one of the posters the first night, people still do single fiber EMG, and if anybody looking for an academic project, looking at ALS patients, for example, pre and post exercise to see if the jitter increases might be an interesting way to analyze whether fatigue could be coming from impaired neuromuscular transmission after exercise. Has that been done?
Not that I know of. I think that's a great comment. I don't propose to be an expert in electrophysiological assessments. However, what I want to highlight and what you point out is assessments on either side of exercise could be very, very valuable. So we'll take one more question. Okay.
So there is, I mean, SMN is in the neuromuscular junction protein. So, and there's a decrement known in patients with SMA, like the myasthenia gravis patients. I just wanted to add to the complexity that as we are treating these patients, as we all know, the improvement in fatigability or perceived fatigue may be at different domains. Some patients may experience an improvement in their voice, in their swallowing functions, in their breathing abilities, and in their endurance. So I would recommend, as you well know and you're doing, to look at the various domains, because some patients, I mean, if we just focus on the neuromotor, we may not capture what's the improvement perceived and actually visible by the impact the drugs are having on these patients in the other domains. So it's really even more complex. It's not just neuromotor, it's very many things.
Thank you, Valeria, I agree. Thank you, and I think in the interest of time, we'll go to our next speaker. Dr. Nicole Woot is from Radboud University. She's going to speak to us on pain, fatigue, and exercise in neuromuscular diseases. Start low, and go slow.
Thank you for the introduction, and how nice to, in the early morning, to talk about fatigue as a lively experience, but also about pain and the solution, exercise. And as you can see, I will talk about personalized medicine, start low, go slow, one size doesn't fit all, and also a little bit of history. And this is a pity, because I thought there was coffee. And when I was looking for an image regarding coffee, I saw that there are many reasons to drink coffee before you work out. It improves ability to focus, it reduces muscle pain, it prevents diseases, increases physical performance, and it helps fat loss. So I propose in Italy a session regarding coffee, including coffee. But now, a little bit of history, because what I tell you now, it's not new, because Gallinus already told about exercise physiology and the positive effect of exercise. He said, hot or cold air, food and drink, rest and motion, waking and sleeping, these are the factors that necessarily influence the body for better or worse. And when, for example, the body is in need of motion, exercise is healthy and rest morbid. And when it's in need of a break, rest is healthy and exercise is morbid. So he already knew the positive effect of exercise and rest. So what happened in between? I think it's the development of medication, for example, antibiotics. And of course, medicine, clinical trials are very important for people for neuromuscular diseases, but preventive medicine is important too. And in my opinion, it's not the one or the other, it's both that is important. So when we take a look on FSHD from a medical perspective, this is just an example. We are talking about disease. And unfortunately, the Dutch language doesn't have a correct translation for disease, but in English it is. So disease, it's about DOX4, modifier pathway, downstream of DOX4, etc. But when I ask my patients, what is FSHD from your perspective, then it's about illness and sickness. And of course, muscle weakness is important, but there's more. More than 60% of patients experience fatigue. Almost 80% of patients experience pain. Sleep disturbances are common. And with all this, it's very difficult to be physically active. And this is the burden of disease for these patients. And you can see, as told before, these are multidimensional problems, just like a Rubik's Cube. And when we take a look on the determinants of health, a couple of years ago, there was a big research, data from, for example, the National Health Service on the determinants of health. And it appeared that only 11% of health is being determined by medical care. So as we are here now together, we are not so important as we maybe think we are, only 11%. But of course, for our population, genetics and biology, 22%. The environment, 7%. Social circumstances, also important, 24%. And then individual behavior is 30% a determinant of health. So important, lifestyle. So let's talk about fatigue. What's the problem regarding fatigue in patients with neuromuscular diseases? We all have a certain capacity, and that's for us all 100%. But there is a difference in absolute capacity. For healthy people, they have a natural reserve up till, say, 60% of their maximum capacity. And up till 80%, compensation is needed. And above 80%, there's a loss of function. And the same is the case for our patients. But you can see that the absolute values are less. And for example, vacuum cleaning, people without a neuromuscular disease can do vacuum cleaning in their natural reserve. But for our patients, maybe compensation is needed or it's not possible anymore. And it's good to know that compensation means that other muscles help the muscle with muscle weakness to perform an activity. And we know that compensation can lead to pain complaints, chronic pain. So it's important to know. Then, regarding fatigability, we already heard about fatigability by Professor Montes before. And here you can see the consequence of a high and a low fatigability. The blue line, for example, top sporters with the lowest fatigability, they have a very huge work of activity. The green line, the healthy people, top sport isn't healthy, but the green line, intermediate fatigability, and the red line for our patients with a very high level of fatigability, and as a consequence, a lower work of activity. But our patients want to do activities just like we do. And most of the time, it's not even the activity itself which is the problem, but it's the amount of rest. And because they have to perform their daily life task, just like everyone else, the amount of rest is less, and as a consequence, the fatigue builds up. And then they are at risk for chronic fatigue. But what is the difference between acute fatigue and chronic fatigue? Acute fatigue goes away after resting, and chronic fatigue not. Acute fatigue occurs after exertion, for example, after exercise in the gym. But chronic fatigue, there is no relation anymore between the things that you do and the fatigue that you experience. And as a consequence, it's very difficult for patients to cope with their fatigue because there's no relation anymore. And it's a long-term chronic fatigue. And it's a multidimensional concept, in contrast to acute fatigue, which is more unidimensional. And of course, it's an unpleasant feeling. So very important to treat chronic fatigue. And then we are talking about the 3 Ps in acute fatigue becomes chronic fatigue. First, there are the precipitating factors. Once in time there was something, an illness, a trauma, that leads that acute fatigue becomes chronic fatigue. But up till now, we cannot change the past. Then there are predisposing factors. For example, a neuromuscular disease. A patient with a neuromuscular disease has a higher risk of developing chronic fatigue. But most of the time we cannot do anything about that. The most important factors are the perpetuating factors. That are factors that make that the fatigue, chronic fatigue, doesn't go away. And several years before, in the Radboud University Medical Center, we developed a model regarding chronic fatigue. And as you can see, fatigue is in the middle, and all the perpetuating factors are around it. And you can see that muscle weakness is only an indirect factor. It doesn't lead directly to fatigue. Or in other words, if you have a high level of muscle weakness, that doesn't mean that you experience fatigue, or the other way around. But it leads to fatigue by means of physical inactivity. Pain is the second most important perpetuating factor, and sleep disturbances are the third most important perpetuating factor. And maybe you recognize the burden of disease for our patients. And with all this, fatigue, physical inactivity lead to a lower level of social participation. And based on this model, my PhD study was built, the FACT-2FSHD trial, which consisted of a usual care group, 16 weeks of cognitive behavioral therapy, or 16 weeks of exercise. And to be short, it was a very positive effect, also after 3 months of follow-up, on experience fatigue, on the level of physical activity, and on disease progression. I come to that back later. And after CBT, also a positive effect on social participation and sleep quality. And the number needed to treat for exercise was only 2.3, or in other words, 2.3 patients had to exercise in order to cure one patient of his or her fatigue. And for CBT, it was only 1.3, so almost effective for everyone. And on average, patients received only 2 to 3 sessions of CBT in order to cure his or her fatigue, excluding homework sessions. And when I called the patients years later, almost 80% of them indicated that they continued exercising because of the positive effect. So why is a psychological treatment so effective on fatigue and even on disease progression? Here you can see the modules of cognitive behavioral therapy in the trial, and you can see that it was also focused on deregulation of activity. So it included an activity program. Also on deregulation of sleep. Patients were asked not to sleep during the day, and as a consequence, the sleep quality at night was better. And when needed, the partner was invited to the therapy, and also focused on coping with the disease and dysfunctional cognitions. So now, the disease progression. We measured fatty infiltration by MRI measurements of the upper leg muscles, and the blue bar is for the usual care group. And as you can see, almost 6% of increase of fatty infiltration in the usual care group in the upper leg muscles. After exercise, that was only 2.5%, and after CBT, only 2%. So in other words, these interventions lead to a deceleration of the fatty infiltration. So a very positive and surprising effect. The same model I showed before was built for myotonic dystrophy type 1, but with two differences. We had to add reduced initiative to the model and also myotonia to pain in order to have a good model fit. And based on this model, again, a randomized controlled trial was built, which is called the optimistic trial for patients with DM1. Now with cognitive behavioral therapy and a usual care group, and if there was inactivity, then there was optional graded exercise therapy combined with cognitive behavioral therapy. And also a very positive effect on fatigue, level of physical activity in this group which with a reduced initiative. And I think that the important thing in this trial was that it all began with reduced initiative. There was a specific model included in the cognitive behavioral therapy focused on reduced initiative, and no effect on fatty infiltration, but a positive effect on the increase of muscle tissue. So again, a disease decelerating effect. My colleagues in the Amsterdam University Medical Center who developed the cognitive behavioral therapy, they wondered because it was so effective for chronic fatigue syndrome, fatigue after cancer, fatigue after rheumatoid arthritis, etc., and all the neuromuscular diseases, is fatigue a disease-specific or a generic symptom? And it appeared that in only 10% of the time, experienced chronic fatigue is disease-specific, and in 90%, it's a more generic symptom. And that's because most of the time it's not a direct factor of the disease, but an indirect factor. And therefore these therapies can be effective for a very large group of patients. And then another study by Erik Voor, my colleague who presented before from the Amsterdam University Medical Center. He conducted a survey among healthcare providers, because there are still some hurdles regarding implementation of exercise. And more than 80% of healthcare providers believe that aerobic exercise should be incorporated into neuromuscular care. However, almost 80% believe that there are still barriers for application regarding screening and dosing, exercise prescription. So there's a lot of work to do. And what are barriers? Clinicians have concerns regarding safety, and they have a lack of knowledge regarding exercise, and they are still afraid of overwork weakness in patients. And patients, on the other hand, more than 70% of them are unable to perform the desired training level, which maybe lead to poor motivation, and also, again, still experience of fatigue. And I think what's lying behind it is that there are different types of people. And many of my patients say, I maybe have a neuromuscular disease, but that doesn't define my personality. So my advice is take a look at the person in front of you in your consulting room when prescribing exercise and ask, do you like exercise or not? What did you do regarding exercise in the past? Do you have a family, hobbies, work? It's so important when prescribing exercise. It's not only about the disease. And then how to measure exercise capacity and fatigue. The gold standard is still a maximal aerobic exercise test on a bicycle, for example. But then we receive the aerobic capacity, which is a sum of muscle, heart, lungs, mitochondria. And for our patients, we want to know what is the component of the muscle and the mitochondria. And that led me to add electromyography in addition to maximal exercise test in patients with NMD. What we did was we included 32 NMD patients, 24 healthy controls, and they all underwent a maximal cycling exercise test with a steep REM protocol, and we performed EMG measurements on leg muscles, because we know from literature in the past that looking at the EMG signal on the right, you can see that at the aerobic threshold, so the first ventilatory threshold, there is also a deviation in the amplitude of the EMG signal. And that's expected because an increase of lactate is lying behind both measurements. And then with the anaerobic threshold, the second ventilatory threshold, again a more pronounced deviation in the EMG amplitude. And I wondered, what about our patients? Do they have the same timing of these EMG thresholds as a measure of muscle fatigue? And here you can see the main results for the two thresholds in time. And the black dots are for the patients and the white dots are for the healthy subjects. And on the Y and the X-axis, the power cycled and the timing at a different power. On the right side, you can see the second EMG threshold. And as you can see, the dots are more or less on the line, which means that there is a perfect timing between the ventilatory threshold and the EMG threshold. But then for the first threshold, you can see that there's a difference between the black and the white dots. And in short, what we see is that patients compared to healthy subjects have a relatively early threshold for muscle fatigue, which was expected. But then I thought patients are exercising according to guidelines for healthy people. And there's a great risk that, for example, when they exercise at 50 to 60% of their heart rate reserve, they are already beyond their muscle fatigue threshold. So then I started to say for patients who are more severely affected, start low and go slow. And to my positive surprise, there were a lot of patients who were not able to exercise before, who were now able to build up their exercise intensity. And what we want to do in the future is to measure again the EMG thresholds, the muscle fatigue thresholds, to see if they have increased with this revised protocol. But then our body wants to prevent fatigue. And how do we prevent fatigue in a certain muscle? We see that other muscles are going to compensate in order to perform a certain movement. And we can measure movement by motion analysis, which is used frequently in rehabilitation. On the left-hand side, you can see athletes with a perfect technique, all the same technique. And on the right-hand side, a very famous moment in the triathlon competition. And two brothers, and which of the brother is experienced the highest level of fatigue? Is it that brother or that brother? Please point out. Yes, thank you. And I will give you the answer. You can see it because of his motion. He has a different technique than his brother. So then I thought, why not add motion analysis to maximal cycling exercise tests? And why is that important? Because compensation can lead to pain. I noticed that in my consulting room, patients experience pain most of the time in the compensating muscles, not in the muscles with a very high level of muscle weakness. And now we make a training passport for patients based on exercise tests with EMG and motion analysis. And here you can see such a training passport. And you can see the two ventilatory thresholds, the vertical line, and you can see the angle, motion analysis, for example, the left upper corner, and the right upper corner for pelvic tilt, spine lateral flexion, and the lower graph for the EMG. And we take a look at, this is the red vertical line, when we see compensation and muscle fatigue. And you can see for the pelvic tilt and the rectus femoris that there's already muscle fatigue before the first ventilatory threshold. So for this patient, I changed this exercise protocol. Normally I would say exercise around the first ventilatory threshold, so about 48, a power of 48. But now I say exercise up till a power of 30. And then this patient came back to me in my consulting room, and he showed me his body battery. It's a function of a Garmin smartwatch. And the body battery, normally you have a body battery of 90% when you wake up. Maybe not today, but normally. And you can see what is happening. He has a body battery of sometimes only 25. So very low. And then you have to have a day behind. But then I gave the revised exercise advice. First, he has a very low battery, and then you can see what happens. His body battery increased. So maybe this is very helpful, start low and go slow, to increase body batteries of our patients with a high level of muscle fatigue and muscle weakness. And there's another advantage, maybe you know from the top sport polarized training. It's also included in the trial of Erik Voorn. most of the time very easily exercising, but also high intensity, 10%, and nothing in between. And when we exercise easily, then there is another advantage, is that we burn fat. And for our patients, it's very difficult to burn fat, and they not to gain weight. So that's another advantage of start low and go slow. In short, because of the time, we also performed muscle fatigue measurements in boys with Duchenne with arm support. Many of my patients are afraid to use arm support because then my muscles will become lazy, but it's the other way around. The upper graphs show the level of muscle fatigue and activity without arm support. And you can see that there's a very high level of muscle fatigue, but that they are not able to be active for a very long period of time. The lower graphs show the activity and the muscle fatigue with arm support. And then you can see that there is less muscle fatigue and they can be more active for a longer period of time. So use aids. Because that's so important. Explain to your patients that aids, walking aids, arm support, all lead to a lower level of fatigability, and to that, to a higher work of activity. And then already mentioned Tina Drong from the Stanford University, she also used open cap. Open cap is already mentioned earlier this Congress. Because normally a traditional outcome for trials is, for example, the sit and stand test, how to get out of a chair, a 5-point ordinal scale. But open cap is different because it's more objectively and it uses motion analysis to measure motion and fatigue. And I think it's a very reliable outcome measure also for clinical trials. So to end, I have told you about exercise, pain and fatigue, so keep in mind how important personalized medicine is, a training passport, that is all not new. One size doesn't fit all, and the most important message is start low and go slow. And I want to thank all the people from the Radboud University Medical Center, which is a multidisciplinary team, for receiving these results. Thank you.
Thank you, Dr. Voot, for an outstanding presentation and a really comprehensive body of work looking at fatigue and fatigability. Questions for Dr. Voot?
Thanks. I just had one question. So I also did a sports fellowship, so I'm used to treating concussion patients, and for them, this is kind of what I give them, and I give sort of a miniature version for my neuromuscular patients. I usually just tell them 15 minutes on a stationary bike, heart rate above 100. Do you think that's a good starting place, or would you add anything on to that in terms of just a model or progression for our patients?
Yeah, thank you for your interesting question. And of course, we do not all have the possibility to perform a maximal exercise test and not EMG motion analysis. And therefore, start low, go slow has another advantage, because when you start low, maybe it's not so effective in the beginning, but when you build up, you come to a certain point that it is effective. And what I tell my patients or their coaches or their physical therapists is to take a look at the motion during the exercise, because when the motion or the movement is going to change, that's a sign of muscle fatigue and compensation. And of course, heart rate watches are very important. And Erik Voor, my colleague, also developed a test which can be used also to measure the thresholds. But if you're not certain, for example, if your patients have a more relatively higher level of muscle weakness, then yeah, to be sure, you can start low. And the third advantage is that when you are able to build up your level of intensity, that's more positive and has a very positive influence on self-efficacy than the other way around, that you start at 50% and you have to go back to 30%. Yeah.
Thank you. One more, two more questions here.
Thank you so much for the wonderful talk. So the question might be a little bit broad, like do you have any difference in approach for like reversible conditions, the more acute pathology like myositis versus more genetic, like one-way progressive disease? What would be your difference in approaches?
Yeah, I can talk an hour about that. So, of course, for our metabolic myopathies, myasthenia gravis, for myositis, there are certain things to take into account. For example, during a flare-up in myositis, be careful with exercise. Of course, for certain metabolic myopathies, you have to, for example, McArdle disease, have to prescribe exercise in a different way. So I always say the person is the most important, but of course there is a disease and there are certain guidelines regarding the disease. But I'm now building up a kind of knowledge bank with all these prescriptions so that we can learn from each other and how to prescribe exercise for certain groups of patients. And of course the cardiac problems, cardiac comorbidity. So there are certain guidelines, but the time is too short to get into detail, which have to be taken into account.
Great. Last question over here.
Hey, thank you. That's wonderful work and such important work, I think, for all our patients. Did you look at microvascular function, and do you think it plays a role in this and it's worth tracking over time for these patients?
Yeah, thank you. Interesting question. I didn't take a look at microvascular function, but yeah, I'm sure that it will have a role into the function of the muscles, because we know in healthy people that it plays a role. And now in the Netherlands, we have submitted a grant for an MRI scanner in which people can exercise. And then we will also take a look at microvascular function, muscle function. We can add ultrasound. So I hope that all these different outcome measures together give more insight into muscle function. But I know for sure that it will play an important role. Yeah.
Great. Thank you, Dr. Vu.
Thank you.
Great. So next we have Dr. Ralph Rodriguez-Torres from Columbia University, who was last year's Shark Tank awardee, who's going to give us an update, and the title of his talk is Perceived Fatigability Tracker, Improving Assessments to Enhance Spinal Muscular Atrophy Patient Outcomes.
Thank you, Jackie, and I hope you guys aren't fatigued about talking about fatigue. So I'm Ralph Rodriguez-Torres, and I'm happy to be here to provide an update on the Shark Tank Award I received last year. So Jackie did a really nice job of covering fatigue and fatigability and how they are intractable symptoms that impact patient well-being and physical function. She discussed fatigue terminology and how it has been used pretty broadly and sometimes interchangeably to describe several different experiences and observations. Clinically, this experience or patient-reported experience is quantified with patient-reported outcome measures. However, there have been several inconsistencies in the methodology applied to the assessment of patient-reported fatigue, which often leads to a discordance between what patients report and how they perform. And she also touched on how the underpinnings of the symptom of fatigue and fatigability in SMA remain poorly understood. So this was from the most recent Cure SMA State of SMA report, where they stated that despite earlier diagnosis, improved care, and advances in treatment, significant unmet needs persist. And among 226 adults who were surveyed, 85% reported reducing fatigue as a priority. This was a study conducted by colleagues in Spain, where they organized focus groups with individuals living with SMA as well as their caregivers to identify priorities for assessment in SMA. They found that disease burden is experienced across the physical, social, and psychological domains. And within the physical domain, fatigue, fatigability, and strength were identified as top priorities for assessment. They concluded that the current functional scales we know are clinically relevant but may be inadequate to capture the complete patient status. And of course, the continued emergence of new therapeutic options for SMA necessitates robust outcome measures to track disease progression, including patient-reported outcome measures, especially those that are specifically designed for SMA. So what is the evidence for patient-reported outcome measures in SMA? In 2022, Jeremy Slater and colleagues published a scoping review that identified 31 distinct patient-reported outcome measures that have been applied to SMA, many of which have been repurposed from other conditions. They found that most have been focused on the physical function, mental health, and cognition, as well as fatigue, with a lot of overlap. And despite their wide use, there are several gaps in the psychometric evidence for the use of these patient-reported outcome measures, as most have been focused on establishing concurrent validity. So we know that people with SMA tend to perform worse on current patient-reported outcome measures compared to people without SMA. However, the responsiveness to subtle changes and the impact on treatment in SMA is unknown. And in a rapidly evolving treatment era, of course, this is of utmost importance. So Jackie showed this image in her presentation, but it's just covering how multidimensional, how fatigue assessment has been multidimensional in SMA. But physical fatigue, which is proposed to be the most relevant to the pathophysiology of SMA, although it has been queried with some disease-specific and some non-disease-specific scales, there have been limitations to assessment of physical fatigue. Many of these limitations stem from how we define physical fatigue. So Jackie provided the definition of performance fatigability as a decline in one or more aspects of performance or decreased motor output over time. And she covered how we have pretty good clinical tools to capture this experience of fatigability in SMA. But I want to add an additional definition, and that is perceived physical fatigability, which is the whole body measurement of one's susceptibility to fatigue with physical activity of fixed intensity and duration. In SMA, none of the current patient-reported outcome measures assess physical fatigability using this definition. So 3 years ago, we set out to develop a novel SMA-specific patient-reported outcome measure to standardize the assessment of perceived physical fatigability, or PPF, in SMA in individuals ages 12 and older. The emphasis on this scale is the intensity and the duration of the physical activity, which we believe aligns closer to that definition. Initially, the activities we included on the scale were separated based off of 4 activity domains, which are shown here, which are based off of estimated energy expenditure levels, or METs. There was a broad item pool with differing intensity and duration to capture this experience across the spectrum of SMA, limiting floor and ceiling effects. And the additional novelty in this scale was that individuals were only to rate activities that applied to them. So this just shows the branching logic that was used to guide participants through the questionnaire, where they were asked, have you completed this activity in the past month? If yes, they were then asked to rate their level of PPF using the Likert scale on the bottom. And if no, they were then asked, have you ever performed this activity in the past? And if in fact they had performed the activity in the past but had lost the ability over time, they were still able to rate this activity. And since individuals were only to rate relevant activities, we created a simple scoring algorithm to generate a total score and a subscale score, with higher scores indicating greater PPF. And as part of our pilot study, we sent out this questionnaire in anonymous fashion to identify the most relevant physical activities to include in the next version of the scale. Our data collection spanned an international cohort with individuals with all types of SMA and a pretty broad age range. And this just shows the breakdown of the participants that completed the survey by current function. So when I presented my Shark Tank proposal last year, the priorities that I outlined for funding were to recruit biostatisticians and scale development experts to help us make sense of some of the pilot data we had collected, to conduct cognitive interviews with individuals with SMA, to help refine the items on the scale and improve the interpretability of the questions, and also to begin or to build a digital version of the scale to allow for a more user-friendly tool. We were successful in recruiting scale development experts from Columbia University in the School of Public Health and the Data Science Institute. We were able to complete cognitive interviews with individuals across the spectrum of SMA, and we are currently in the process of working with a database manager who's building out the digital version of this tool. And in the meantime, we've also named the scale, which is now being referred to as the SMA effort. So as you recall, the initial activity breakdown was based off of energy expenditure levels. However, as there is limited data on metabolic equivalents for neuromuscular disease, specifically SMA, we have reorganized the activities based off of these 4 domains, which align a bit closer with an ICF framework. And the analyses that I'm going to show you are only based off of the activities that were endorsed in the past 30 days. As you recall, in the initial version, we allowed individuals to rate their level of PPF, even if they had lost the ability over time. However, this proved problematic. So these analyses are only based off of the individual's current function. So here what you can see is that when we looked at the total PPF score based off of current function, while the scale was able to differentiate based off of functional status, what stood out to us was the variability that exists, even within the functional groups. And we had also collected some simple clinical variables. So on the left, you can see that individuals who reported use of respiratory support reported greater levels of PPF compared to those who reported no such use. And then on the right are the results by subscale. Again, some subscales were able to differentiate based off of functional status, but the large variability within the functional groups stood out to us. We also considered a more complex factor analysis model, which is commonly applied to scale development research. And there was poor item fit due to a large proportion of missing data. As you recall, individuals were only able to, or encouraged to rate activities that were relevant to them, so that meant that there was a lot of missing data. Still, when we looked at the correlation analysis between the total score using that simple scoring algorithm and this more complicated latent factor score, there was a high correlation between the two. Still, we're choosing to go forward with the simple scoring algorithm because, again, this more complex factor analysis modeling extrapolates information based off of participant functional status and their rating on activities that they do perform to sort of give you an estimate of what they would report on activities that they don't perform. So this is just a highlight of the first version of the scale where the questions were presented in a randomized fashion. Again, individuals were allowed to rate their level of PPF with activities and or abilities that may have been lost, and there was some item redundancy. Now the scale has been improved. The questions will be presented by activity domain. Individuals will only be able to will only rate activities currently performed, as in the past 30 days. And we have improved the question structure, including the organization and the readability, where the feedback that we received during the cognitive interviews was really informative here. So this just shows the face pages that individuals will be able to see prior to answering any question for any particular activity domain, to sort of just give them a summary of what they're about to answer on. And this is just one example where it's asking, in the past 30 days, have you completed the following activity, aerobic exercise, with the intensity being somewhat heart-to-heart effort. Participants will be able to hover over those words where they will be presented with a visual like this one, with where they'll be able to see what somewhat heart-to-heart effort visually represents. If yes, they will then be asked, what is the usual amount of time you spend doing this activity, the minimum and the maximum, and they will still be able to rate their level of PPF using the same Likert scale for the time that they have indicated. So we're in New York, and this is the George Washington Bridge, for those of you that don't know, and it's right next to our medical center at Columbia. And this was a timeline that I presented with my proposal last year. On the left were the priorities for the Shark Tank funding, and I'm happy to report that nearly all of these have been completed. We had also planned to submit a research grant for the validation study to the MDA, and we did submit the grant, and while it was not funded, we did receive really helpful feedback, which has now been adapted into a new proposal that is currently under review and will allow us to achieve some of these initial validation priorities while capturing this experience in a treated cohort, including fluctuations in this experience. And looking beyond, we still hope to apply to a larger federal, for a larger federal grant to characterize fatigability in SMA more longitudinally, where we hope that the SMA effort will be an additional piece to the puzzle to help characterize fatigability alongside electrophysiological assessments, motor function, and performance fatigability assessments, as well as capture the impact of treatment. So just to recap, fatigue is a problem in many neuromuscular diseases. Here we're focused on SMA. The pathophysiology is multifaceted, and we hope that an improved assessment will lead to better treatment opportunities. And with that, I would like to thank my mentor, Dr. Jackie Montez, the Montez Lab, my colleagues at Columbia University, including in the programs in physical therapy, the Department of Neurology, the Mailman School of Public Health, as well as collaborators at the University of Pittsburgh, and within ISMAC and PNCR, specifically Dr. Mike McDermott, and of course the Neuromuscular Study Group for your funding support. And good luck to this year's contestants.
Thank you, Ralph, for your great work. Questions for Ralph? They're all fatigued. I'll ask a question. So what do you think, so the SMA effort, where do you think it would be best applied? Like in a clinical setting, in a research setting, both? What will be its best utility?
I mean, of course, as we finalize this next version of the scale, I think in a research capacity, really understanding the psychometric properties and honing in on this, as to Dr. Sansoni's point, the domain of perceived physical fatigability will be really helpful. And then, of course, capturing, using this patient-reported outcome measure and looking at the impact of treatment and some of the electrophysiological assessments you touched on will be really helpful. But yes, eventually we hope that this would be utilized in the clinic.
Great. You have a question over there. The microphone's coming.
I got the mic for now.
Oh.
Thank you very much. Great talk. Wonderful ideas. I've seen Shark Tank. How did you propose to monitorize this?
Say it again?
How did you propose to monitorize this? Apropos to Shark Tank.
So, I'm not sure I understand your question. Yeah, go for it.
That's a great question. I was going to make a comment that this is wonderful, great work. This is just, I know, what we envisioned at NMSG leadership for our junior people to do, to be coming up with new ideas like this. So how do you monetize it? It's different in the academic world from the industry world. So the way we monetize things, at least in the short game, is by getting the next grant. But in the big picture, it's the long game, isn't it? So I really think it's our job in academics to be working on these scales early in our careers, and you never know what's going to happen to them. The one possible route is that once these scales get used in academia for our investigator-initiated projects, that eventually, once drugs come available, that industry picks them up. And I will just say a little example is the myasthenia gravis ADL that Gil Wolfenlaw and I did back in the early 90s, and we were just trying to get our first grant. And look what's happened to the MG-ADL. All the MG companies are using it. And so it's a long game to monetize it in the academic world, but it's the game we're playing, and great job.
Thank you. Sorry I didn't understand your question.
One more question over there, and for Gita.
Thank you. Fantastic work, Ralph. I suppose my question is that as we heard from some of the earlier talks, fatigue is a really, really common symptom across lots of neuromuscular conditions. And I think what's really striking with SMA is that it actually spans such a big breadth of functional ability. Do you think to apply the effort scale to other conditions, would we have to go back to individual conditions to see how fatigue might present similarly or differently, or do you think this is something that we could explore across other conditions as is?
It's a great question, and one that we receive pretty often. I think that the framework in terms of how we're defining this experience, perceived physical fatigability, and anchoring, being intentional about anchoring activity to the intensity and duration, is certainly something that can be applied to other diseases. Whether the specific activities we have included are relevant to those other conditions would be something that can easily be adapted, but the framework, I think, applies throughout.
Thank you. Excellent job.
This is the 6th Shark Tank session. And there's Liz provided me with some history for those of you who have not attended all the previous sessions from 2020 until this one, including the winners. So you can take a picture if you cannot read all the small print. The sharks today are experts in their field. James Lilliker is an MD, PhD from University of Manchester. His focus is inflammatory muscle disease. We try to choose sharks with different focuses in order to address different presentations. Senda Adris is a professor of neurology from Northwestern, and she leads an ALS clinic. Gordon Smith is the chairman of the Department of Neurology at Virginia Commonwealth University. And Amanda Guidon is the chief of neuromuscular division at Mass General. So we are very lucky to have a very distinguished group of sharks who are going to hopefully address different areas and different presentations to improve them. I have been learning about sharks over the last few weeks. For the sake of this presentation, there are 3 types of sharks. Tiger sharks, these are responsible for most of the unprovoked shark attacks. Nurse sharks, this is the first time I hear about this, they have low metabolism. They sit motionless on the sea floor, usually against the current, so the current will bring to them the food and drinks while they are sitting there. And then lemon shark is the color tails. These are, although large, powerful, and carnivorous, they do not impose risk to humans. And our sharks are selected and trained to belong to category C. They are trained not to attack humans, but to attack projects and proposals. proposals. I would like to thank several people here. I mean, our leaders, Rick Barron and Mike Hanna, have spent a lot of time. And congratulations for another successful conference. This is an amazing group of people that you don't see anywhere else, and with a big intention to raise young investigators. You don't see this forum anywhere else. So thank you very much for your leadership, Rick and Michael. Also, thank you to the scientific committee, and in particular to our reviewers. We have received 10 proposals. I hope next year we are going to receive more, especially we are going to meet in Italy. So these were reviewed by Professor Valerie Sanson, Dr. James Lilliker, and myself. Those who did not win, you know, Rick Barron always have great ideas. Say those who did not win, let us give them an opportunity to post their posters, and we'll pay for their rooms so that they will learn from remarks of other people and comments from other people, and they can reapply. One person that has done, at least I have been in touch with her almost every day. She responds to my emails, even if I send her an email in the middle of the night. She has been detail-oriented, but she told me she is going to retire next year after the last conference in Italy. So I wanted to thank her very much. I want you to extend her, always when you see her, your thanks and appreciation. That's Liz Rosso-Polk. And Liz, please come to the podium. I have a small gift from Texas for you. Can you open the door? I asked Liz to be here. So open the door, please, and get Liz in. Yeah. She is outside sitting. Yeah, great. The scoring system is very fair. As you see, the sharks have forms, and they are going to look at the quality of the audiovisual. You are not supposed to present more than 3 slides. So we're going to be very sharp in terms of time and in terms of pacing ourselves. The importance of research, the feasibility, the impact, and the overall rating, and some feedback from the sharks for the future. The winner is expected to present an update the following year as we did this year. And as I said, we have 100 minutes and 4 presenters. Each one is going to have 25 minutes, 5 minutes for the presentation, 15 minutes for the sharks to attack and reform and improve, and 3 minutes for the questions from the audience. To be very transparent, James suggested that we ask some of the people from the audience to ask questions because this is their area of expertise. So in case you see someone raise their hand and they are very prepared to answer questions, know that this is a staged democracy. So I'm going to ask Liz to come to the podium. And I have 2 gifts for Liz. In Texas, we take woodwork seriously, and we make a lot of woodwork from fallen trees. So this is a trunk of a tree, has 2 drawers. You can put pepper, salt, whatever you like, very well polished, very well done. So this is one. Thank you. All right, thank you, Liz. Since Liz is retiring, I have a kitchen board. It has every animal you can see in Texas, including kangaroos and penguins. We have kangaroos in Texas. So this is going to be very nice for making whatever. If you are vegetarian, you can do veggies. If you are meat eater, you can do steak.
Thank you.
That's good. Thank you, Liz. Thank you very much, Liz. Thank you very much. Great efforts. Okay, and be careful, don't fall. Thank you. All right. So how many minutes did I take? James, you are timing for me? Okay. Okay. So we're going to start. The first presentation is MRI as a biomarker in periodic paralysis, a prospective longitudinal pilot study in periodic paralysis. And for me, this is a new topic, but Dr. Lillicard wanted me to be the shark for this because he has a conflict of interest. He's part of this presentation. So I tried to prepare myself. I read some about this. I discussed that with Vino also. Oh, please. And the presenter is?
It's not this one.
I don't have a conflict.
Oh, I see here, this one.
Yeah, but you're not the shark on this one.
Not on this one? Okay.
It's had to be in English.
Who's the shark on this one?
Me.
Oh, you, okay, great. Okay. Oh, that relieves me. Okay, good. Thank you. Go ahead.
And I think we let people have 5 slides as well, just in my role as the low metabolism nurse shark. I thought we'd let them have a couple of extra slides.
Okay.
Great, so thank you for this opportunity. Good morning, my name is Marwa, and that is a picture of me the last time I went swimming with sharks. I'm hoping to emerge again today with 2 thumbs up. Over the next 5 minutes, I'm going to tell you why this project, MRI as a biomarker in periodic paralysis, deserves your investment. At the outset, I'd like to thank my senior colleagues for their support. Periodic paralysis, these are rare, dominant genetic disorders caused by mutations in ion channel genes. Although rare, symptoms of this disorder start in childhood with debilitating episodes of weakness, pain, and yes, fatigue. This progresses eventually to permanent weakness. And at the moment, we have some symptomatic therapies, but we do not have any convincing disease-modifying therapies to prevent disability in these young people. This weekend, we've heard a lot about the emerging genetic therapies and how we're now riding that wave, excuse the pun. But before we can progress to treatment trials in periodic paralysis, we need a reliable outcome measure. Because of the inherent variability of symptoms in periodic paralysis, clinical scores are not suitable for this purpose. We need something that can achieve early detection, monitor progression, and, importantly, track response to therapies. We want to meet that urgent need with an MRI biomarker, which can visualize these changes earlier and more reliably, not just in periodic paralysis, but potentially in many muscle wasting conditions. At the moment, we know that standard T1-weighted images of lower limb muscles in periodic paralysis show fat accumulation, and that increases with age. But this is detected relatively late in disease and is not reversible. So we're already in the jaws of the shark at this point. On the other hand, diffusion-weighted imaging can detect changes in the microstructure of tissue, and so potentially can detect pathology in muscle before these irreversible anatomical changes. We know from animal models that diffusion imaging can detect changes in myofibril permeability. And importantly, we know that in channelopathies, muscle membrane permeability is affected. So we believe diffusion imaging is going to be a responsive biomarker in periodic paralysis. We've already demonstrated this potential at our center in Duchenne muscular dystrophy, where we've shown that longer diffusion times can distinguish healthy from diseased muscle before these irreversible anatomical changes and before fat accumulation. So our objective is clear: to explore and finesse MRI diffusion as a potential biomarker in periodic paralysis. At our national program with one of the largest cohorts of periodic paralysis patients in the world, we're going to recruit 5 newly diagnosed patients without fixed weakness. They'll undergo imaging and clinical assessments at baseline, 6 months, and 1 year. They'll have imaging with diffusion imaging along with more standard MRI sequences. They'll keep an attack diary throughout and receive standard of care medications. They'll be started on those. This will allow us to gather longitudinal data comparing MRI diffusion with these more established MRI techniques. It allows us to track progression, track changes, and response to treatments over that time. It will also importantly allow us to define which diffusion times and scan interval times are best to detect this change. And with that knowledge, we're going to build a larger study with matched healthy controls. At our world-class neuroradiology center, we already have MRI and clinical staff in place. So the main costs are going to be MRI scanning time at $590 per scan. And in the interest of inclusivity, we're going to allocate $65 for each patient for each visit for transport. That's going to come to a total of $9,825, and that is going to save you $175. There is no doubt that without a reliable outcome measure biomarker, we can't progress in terms of treatments in periodic paralysis. And so research such as this is critical. Finally, as I mentioned before, results from this diffusion-based study are going to give us a window into many other muscle-wasting diseases, and that is a high return on investment. Finally, I want to thank everyone for their attention, and I'm going to finish with a picture of a whale shark. This is one I took a few years ago with a GoPro. I've included this because whale sharks are the largest shark in the waters, but importantly, they don't bite.
Thank you very much, Dr. Assad.
Shall I start?
Sharks are going to...
Thanks, Merva. Great presentation. Could you start by giving us some more technical details about what diffusion imaging is and how it differs from other techniques?
Yeah. So diffusion imaging, it's a non-invasive MRI technique without any contrast involved, and it takes advantage of this Brownian motion of water, so the movement of water. And we know that in biological tissues, that movement is restricted by membranes, by the structure of the tissue, and so each tissue is going to have its own diffusion properties, and that's going to allow us to distinguish between the tissues. And then, as I mentioned, in channelopathies, we expect there to be this redistribution of water because of the faulty ion channel genes, so we're going to take advantage of that to detect changes early.
So is this DTI?
Yeah, so we're going to measure mean diffusivity and fractional anisotropy, so we'll apply a tensor, DTI.
And
with diffusion weighted, you're going to do both DTI and diffusion weighted?
Yeah, we're going to apply a tensor model, so to measure those quantitative measures.
And has this been done at all in periodic paralysis?
No, not in periodic paralysis. So we're starting with this pilot study to kind of define those measures.
I'm just, I'm hogging the floor a little bit here, but so I don't know a lot about periodic paralysis, but I know there's different subtypes. And are you including all comers or separate?
For the pilot study, we're going to start with sodium channel mutations because we've seen in our previous study that they do show more severe changes on MRI. So we'll start with that, but with our larger study, we'd like to look at the different genotypes.
And I'm just thinking about potential confounders. If this is so sensitive, what if the patient's done a bit of exercise the day before? What if they're having an episode of paralysis? Do you think it's so sensitive that these other factors could influence your findings?
So we're going to give patients some instructions around exercise and things around each visit. And at each visit, they're going to have a clinical assessment, doing manual muscle testing of power. So if they're in an attack, they won't have an image that day. And we're giving them a 4-week window for when we can do the scan around each time point, 6 months and 1 year.
And then perhaps my final question, just in terms of feasibility. So 5 newly diagnosed cases, what's your kind of rate of incident cases in your specialist clinic?
Yeah, that won't be a problem. I think we'll be able to recruit patients quite easily. We see 10 new referrals per month. And we already have some patients selected between cases we've seen in recent weeks and referrals we've received. So I think we'll be able to recruit pretty much straight away.
But without fixed weakness and newly diagnosed?
Yeah, they're quite young, these patients. Yeah.
And is that fixed weakness just physical examination? Or?
Yes.
Yeah, okay.
I just want to point out you're not acting like a nurse shark. You're acting like very great white.
Okay, I'll stand down now.
Let me try. Aren't you concerned that in a longitudinal study there'll be changes that are physiological, and then including, even in a very small study, including a normal control would be very helpful, especially for things like exercise, sedentarity, and things like that. So what do you think of that?
Yeah. I mean, I suppose, firstly, if you wanted to double your investment, we could include healthy controls. But at our centre, we have used diffusion imaging for other conditions. So we have some control data already, healthy control data, that we can use for the pilot study. And then for the longer study, we'll have matched healthy controls.
So I have a couple of questions. So how did you pick the time points? And are you worried that enrolling newly diagnosed patients, you're not going to see anything over a 6 or 12 months? So do you have longitudinal data from muscular dystrophy patients, or how did you come up with that?
Yeah, so that's a really good question. So in terms of the kind of 6-month intervals to start off with, we know that in that time clinically we're going to be able to see their clinical response to the standard medications. Some patients have very frequent attacks, some less frequent, and so in 6 months we'll be able to gauge their response to clinical to medications. But also we know from the fat accumulation studies in periodic paralysis that they can develop changes in a year or 2 years. And then finally, I suppose this is a pilot study, and so that is one of the questions, is whether we need to scan more or less frequently, and that's something we'll be looking at. I guess in other treatable myopathies, like myositis, there can be this lag in when you see the changes up to several months. So I think these time points are the best to start with for the pilot study, and then we'll refine it for the larger study.
So I'm not too smart about MRI scan, but I would think that DTI and diffusion would be susceptible to structural injury to the muscle, right? And obviously with fatty infiltration there is, but is your thought that there's a functional problem in terms of channel function that will lead to increased diffusivity, or are you thinking that you're going to see early myofiber injury?
Yeah, so I guess mechanistically diffusion imaging is really interesting in periodic paralysis because it is these ion channels that are defective, and so you have this movement of water that's abnormal or redistribution of water. So that's kind of why we're looking at diffusion imaging, and we know from other studies that it is sensitive to that permeability in the myofibril permeability. So I guess that's why it's interesting. We will take clinical histories and things and document if they've had a recent injury or anything else to be aware of as well.
And did you think about actually scattering in some scans during an episode? Is that someone like that question? There's a fellow shark.
Yeah, I mean, I suppose the actual attack is kind of electrical, and it's the changes will last for a certain amount of time. So we may see some changes during an attack, but what we're really interested in is the response to treatment, if these changes disappear with treatment, and also if there is a more kind of chronic process in the background that's causing the permanent eventual myopathy.
Great presentation. Do you have clear criteria for when somebody is in an attack and when that starts and stops?
Yeah, so I mean, it's based on the clinical history, really, of when their weakness starts. With the sodium channel mutations, it's often kind of shorter attacks anyway, and kind of or more like hours rather than days, weeks. So they should be able to kind of tell us when it started and finished. We'll examine them as well for any proximal weakness at the time, and usually they can tell us when they feel an attack start. And how long it lasts, and when they feel like they're back to their baseline. But I guess this is why we need a biomarker in periodic paralysis. We don't really have clinical scores that are reliable in measuring attacks or how progressive they are in their disease.
And how are you going to account for treatment effect? So whether patients are on treatment or not, and the possible effect on diffusion?
So we're going to start with untreated patients. Kind of having active attacks, and then we do want to see the response to treatment, so we'll start them on standard medications and keep a record of their attack frequency, what medications they're on, any triggers, how severe their attacks were, and actually correlate the changes with that. So we do want to see if it changes with treatment.
And We've heard, in other presentations, this conference, that at different parts of the muscle, there are different characteristics, like the tenderness, insertion, things like that. Are you standardizing at which part of the muscle you're going to be examining diffusion?
Yeah, we're going to pick points at the thigh and calf and standardize that for each scan.
Anything more specific than just thigh and calf?
In the calf, we're going to go about, we're going to pick bony landmarks and measure from there for each patient.
Great. One more question. And in terms of your budget, so you outline the costs of the scans. Are there other costs that you anticipate associated with the project, and are those covered by other funding, including your time?
So we're actually in a really privileged position at our neurocenter because we already have the staff and salaries in place. And we have the technology, so we have the scanners and the diffusion technology, the coils all already in place. So really it is just the MRI cost and the transport we want to reimburse patients for. But everything else would be in place, so we could start as soon as we receive your award.
I have a quick question. Will you be doing tractography as well with the DTI to look at muscle architectural changes?
So the main things we'd be interested in are the MD and the FA in the first instance, and we have some of those measures in our previous studies in other disorders, so that would be the main thing we'd measure in the first instance.
And are you considering doing any electrophysiology?
Sorry?
Electrophysiology, EMG, like exercise?
So at our clinic, patients, when they, during their first appointment, they have an assessment with the doctors, but they already also have specialized neurophys and genetics to confirm the diagnosis. It's sort of one-stop shop on their first visit, so they will have all those tests, but not repeated, just on the first assessment. Yeah.
Yes.
So how long, I'm just thinking about some of the things you said as we've moved along. So they're going to have no treatment at the beginning, but then there's a 6 months and a 12 months scan. So how long are you going to withhold treatment for, and are there any kind of ethical...
No, so once we have that baseline scan, they'll just start on medication if they need it, on standard medications, yeah.
Got you.
Yeah.
And these patients coming to you, they're usually not on treatment. Someone, a jobbing neurologist in the north of England hasn't tried them on a bit of something.
No, generally not, actually. No,
Okay.
yeah. And we'll pick ones that haven't been. I guess some have family members. It's dominant, so some are already diagnosed, maybe locally, but generally not.
And just around the use of the word biomarker. So is this a biomarker of the progressive myopathy element of the syndrome, or of the periodic paralysis part of the syndrome, or both?
Yeah, both essentially. So at the moment we have this symptomatic treatment, but we're kind of looking ahead, and our center does plan in time to work on an antisense oligonucleotide treatment, but we really don't have any way to measure if that's going to work right now. So this is the first step for that. But yeah, we'd like to see both. I mean, the symptoms they can tell us, but yeah, the underlying progressive weakness would be.
Great, thank you.
We will open the questions to the floor in case you have a couple of questions. Yeah, go ahead.
Great talk, ambitious project. Since you mentioned sodium channelopathies, there are like 4 different phenotypes associated with SCN4A mutations. Is that a desirable or not desirable feature of your study design?
We're going to recruit patients with a periodic paralysis phenotype primarily, and in sodium channel mutations, that would be mainly hyperkalemic periodic paralysis. We're not going to recruit patients for this study with a predominant myotonia or PMC phenotype.
I guess you wanted to know if patients with paramyotonia congenita and hyperperiodic, would this be treated differently than just periodic paralysis?
Well, usually they have a predominant phenotype in our experience, so it'll be the ones with the periodic paralysis in the first instance.
Question over here. Are you going to select patients that have a certain frequency of attacks, because some might be more severely affected than others, and just to try to, are you trying to select a broad spectrum just to try to get a sense of the biomarker?
Yeah, I mean, I think we'd like to see a range. I mean, it is still a rare disorder, so I don't think we can be that selective. But we'd like to see a bit of a range. And even with 5 patients, I think we will see changes in individuals. So it's still going to be very useful.
Yeah, Valeria, you have a question?
So there's one for Michaela, and then we got 2 here, and then that should probably be the last.
Yeah, we still have 3 minutes. Yeah.
So mine's probably pretty quick. Are you going to be scanning both legs, or is it just one?
Both legs.
Okay. Do you know about how long that scan time is? Because when we do it, it's about an hour and a half.
Yeah, so we've calculated about 45 to 50 minutes.
And you already have a protocol in place?
Yes, yeah, we have them planned. And we've spoken through our kind of patient information days and patient surveys about length of scan and frequency, and we have their buy-in. I guess we have the market research for our target audience already, and they're happy with that.
And are you going to be using like a third-party vendor to help you, quantify the measures?
We're going to use the MIPAV software, but we have that in place at our institution. One of our team members has used that before in her DMD study. So.
Wonderful, thank you.
So, Matt?
Yeah, thanks, Merva. I just wanted to ask about sort of the protocol and the sequences in terms of, are you planning to use any sort of new AI techniques that are coming out to optimize the protocol, or has that already been set? And also in the analysis process as well?
Well, we're going to look at the images. The research team is going to look at the images, but I think I mentioned we're going to use that MIPAV software to quantify the MD and FA for us. But no more AI than that right now.
Okay. And thinking a bit more long term, are the sequences available sort of on any standard scanner, do you know? And sort of the rollout of this across scanners, how do you see that sort of standardization across centers?
At the moment, some of the scans are more research-based, but I suppose the pilot study will be to help define which, say, diffusion times, b-values, etc., would be best. And then when we have sort of a standard for those that we can suggest to other centres, it could be rolled out. But this is a rare disease. It's usually seen in sort of specific specialist centres. So there isn't necessarily a need for it to be available in every hospital. Probably just neuromuscular centres in the first instance.
Thank you.
I think we have 2 more questions. We can take 2 more questions.
Did Valeria have one?
Thank you. Aren't you concerned that the 12 months is going to be too short? And also the fact that, if I got it right, you have not focused on the ones having more than 4 or 5 attacks per month? Because we know that the myopathy usually is considered, at least there's general consensus, that it's related to the number of attacks, and it's not an immediate thing that's going to be there. So if you are going to include patients at the start, they may not already have that number of episodes. And so I'm concerned that if you are not strict in the inclusion criteria and the timeline is 12 months, you won't be able to see what you're looking for.
Thank you. Yeah, so I think we're not specifically looking for fat accumulation, which is what sort of takes that longer time to develop. We're looking for earlier changes and more responsive changes to treatment. I guess in our experience, the myopathy can develop irrespective actually of the number of attacks. We don't know for sure that the number of attacks is what causes that eventual myopathy. There's studies and a lot of data show that in some patients they've seen progression. I think it's Dr. Vissing's team have shown that they can see progression even without attacks between scans. But what we're really looking for is those earlier changes before the fat accumulation, because I guess the fat will affect the diffusion in itself. So we want earlier changes in patients without the fat accumulation.
Any more questions? Now, one quick comment. I think you can double up the number of patients if you can negotiate a better MRI pricing.
Yes.
In Houston, we can do this for $1,500. So probably, I don't know how it works in the UK, but it's a good price. So if you want us to negotiate a better price, just give us the phone number.
Thank you.
Yeah.
I'm not sure we have time for any more questions.
Yeah. I think we are done with this case. I think we have enough information.
Thank you.
That was a great presentation. The next case, excuse me. Ironic, yeah. Many ironic things happen, I think. Gordon Smith was telling me yesterday he was called about a patient of him or of his who was bitten by a shark. It was a coincidence. We are here talking about sharks, and he told me yesterday. Yeah. So we all talk about myasthenia gravis, musk myasthenia, but we never thought of it as being generated outside the muscle. So here we are going to see a presentation about is a mucosal trigger responsible for musk myasthenia by Dr. Massey from Yale.
Thank you.
Thank you.
So good morning, Sharks. Good morning, everyone. My name is Gianvito Massey, and today I'm very happy to share with you our project on musk myasthenia gravis. So in musk myasthenia gravis, autoantibodies, mostly of the IgG4 subclass, bind to musk, causing the dispersal of AChR clusters on the muscle end plate. This event causes the failure of neuromuscular transmission and muscle weakness. Now, despite the efficacy of B-cell depletion, patients do experience relapses, suggesting that an unknown trigger can sustain the regeneration and proliferation of musk-specific B cells. And now, the $1 million question, or today I hope the $10,000 question is, what is the trigger responsible for musk autoimmunity? Well, some B cells may have a story to tell. At mucosal surfaces like the gut, B cells release IgA antibodies that bind to bacteria, protecting us from infections. In some cases, these B cells can class switch and fuel an immune response dominated by IgG. And here's the twist. According to the mucosal origins hypothesis, if a bacterium mimics a self-antigen, immune tolerance can be broken in predisposed individuals, and autoimmunity develops. Well, now I bet you're curious about IgA and musk myasthenia, right? Well, I was curious too. So one day in the lab, I decided to test a large set of samples from musk myasthenia gravis patients, and I found that a subset of them were positive for musk IgG and musk IgA antibodies. Intriguingly, the IgA response was long-lasting in some patients, resisting multiple cycles of rituximab. So, based on this finding and parallels with other autoimmune conditions, my hypothesis is that gut bacteria can perpetuate musk autoimmunity via molecular mimicry. So, Sharks, are you ready? This is my proposal. Well, to test my hypothesis, I will isolate musk-specific IgA B cells. Now, the identification and isolation of antigen-specific B cells is very challenging because these cells are exceptionally rare in circulation. But you know what? We like challenges, and actually our efforts have paid off. Now we have an experimental pipeline to isolate these cells. And then we're gonna apply single-cell transcriptomics that will give us a unique fingerprint of each B cell. Through this information, we'll be able to generate patient-derived, musk-specific IgA monoclonal autoantibodies. These autoantibodies then will be a tool to screen a library of more than 800 bacterial strains that derive from the gut and were isolated from a pool of individuals. Specifically, I will leverage IgA-seq. This is a technology developed at Yale that combines bacterial cell sorting and sequencing in order to identify the bacterium bound by these antibodies. But you know what? There's something more. These IgA antibodies can be wonderful tools to ask focused scientific questions. So, for example, what's the role of these IgA at the neuromuscular junction? Well, we can study musk myasthenia gravis in a dish. So on the left, you see healthy muscles, and the dots represent AChR clusters that are fluorescently labeled. When we add pathogenic IgG4 autoantibodies, the clusters are abrogated, mimicking what happens in vivo. Now, what about MuSK-specific IgA? Well, our preliminary data suggests that these IgA antibodies can actually activate MuSK and strengthen the neuromuscular synapse. This finding uncovers their therapeutic potential. So the funding will be essential to execute a crucial aspect of the project, and specifically the application of the IgA-seq technology and related costs, such as the flow cytometry antibodies, the bacterial cell sorting, and the sequencing. So what are the implications of this study? Well, this project could lead to the identification of a previously uncharacterized gut-muscle immune axis, leading to the improvement of our mechanistic understanding of MuSK initiation and relapses. This could lead to targeted therapeutic interventions, like, for example, targeting the gut microbiota. But also, if we think broader implications, this study could also lead to new insights, for example, for IgG4 autoimmunity. And given the anticipated agonistic effect of the IgA antibodies, these antibodies could also have a therapeutic effect on other neuromuscular conditions characterized by NMSG instability. I thank all of you for your attention, and I'm very happy to take questions. Thanks.
Great presentation. I found it curious that you did not see any early in your preliminary testing, any involvement of IgA and acetylcholine receptor positive MG. I don't know whether you have thoughts about that. I saw that there were a lot more MuSK patients included, but even I think there's some preliminary data in other autoimmune diseases for involvement, so it's just surprising. Do you have thoughts about that?
Yes, well, I have to specify that the assay that we used was a MuSK-specific cell-based assay. So we were looking specifically for MuSK-specific IgA. And we found those antibodies in a subset of the MuSK-MG patient cohort, but not in healthy donors or SHR patients.
I see.
But actually, that's a good point, because our next step will be to actually look for SHR-specific IgA antibodies in the SHR-MG group as well.
Got it. And are you going to be using samples that you already have, or are you going to be collecting new samples, and are these treatment-naive patients?
So actually, these are patients that are on different types of treatments. And intriguingly, we found that 10% of our cohort, so we screened up to 112 samples from 35 patients, and we found that 4 patients had a very high titer of MuSK-specific IgA. So for the generation of MuSK-specific IgA monoclonal autoantibodies, we can use these patients. And actually, we already have made some progress in the IgA quest. We have actually some IgA monoclonal antibodies that we're going to use as tools to screen for bacteria. But we also have an ongoing collaboration with Italy, for example, where I'm from, and we also have a big cohort of patients from there. We're going to collect PBNC as well and test those patients.
And are you going to have clinical data that goes along, whether the patients were in exacerbation or not at that time?
Yeah, so these are actually curated clinical samples with a lot of clinical information. What we observed, obviously, we found MuSK-specific IgA in only 4 patients. So obviously, we cannot generalize. However, it's interesting that also when patients are in remission, the MuSK-specific IgA titer is still present. And so actually, this led us to hypothesize that the MuSK-specific IgA B cells can actually act as a source of pathogenic IgG4 B cells. And so, although the patients are in relapse, after some time, if there's class switching between IgA and IgG4, then disease can present again.
And how do you imagine, potential therapeutic interventions being developed as a result of your data?
Well, I would say that obviously this is like a big ambition, but if we find a bacterium, for example, that is responsible for triggering MuSK autoimmunity, well, the field of gut microbiota is expanding, and there are specific therapeutics, for example, from dietary intervention to fecal transplant to a specific bacteriophage targeting of bacteria. So we can, for example, attack specific bacteria without impacting the good ones. And obviously, there are actually some interesting insights from the field of like rheumatology and rheumatoid arthritis, where like a specific bacterium, Pseudogradulanum, was basically found to be a trigger for both IgG and IgA autoantibodies, leading to inflammation of the joint.
I have a naive question about the methodology, and along the lines of the acetylcholine myasthenia. We do know that the environment, the gut microbiome is involved, and there are strains of bacteria that are kind of goes along with exacerbation or worsening of myasthenia. Wouldn't it be easier to actually test those first than trying to kind of throw a wide net?
Yes, we actually thought about that. As you saw, we thought about using a curated library of gut bacteria. We wanted to do this in order to perform an unbiased analysis. However, we also think that it's important to also look, for example, at the bacteria in the MuSK-MG patients, for example. The only problem is that if we collect bacteria, for example, from the stools of patients, those bacteria obviously will be covered by IgA already, because IgA can actually bind to MuSK, for example, but also to other targets. So in that case, using our IgA monoclonals as probes to detect which bacteria is bound by the antibody itself could be a little bit tricky. We actually have some ideas about that, how to tackle that, but we're also considering that as a second plan.
And knowing that the patient will be on immunosuppressant, will you be also looking at the gut microbiome of their kind of people who live with them, like spouses, or will you have controls?
Yeah, that's a very interesting point. And actually, we think that, there are two different hypotheses. In one case, we can think that there's like a bacterium that is present only in MuSK-MG patients that is triggering the disease. However, we like to think that there's like a ubiquitous bacteria through which, against which the MuSK-MG patients can develop a specific autoimmune response, while, for example, members of the family don't. And there are obviously some genetic factors involved in that, but we can use the members of the family as controls as well.
So I have an even more naive question. So your theory is that gut microbiome specific bacteria and IgA-mediated attack on that molecular mimicry, and then we have these IgA clones that bind to MuSK, and presumably there's slop over to IgG4. So these patients, do they all have an IgG4 antibody as well?
Yes.
So why not just look at the IgG4 antibodies? And then do you think this is only true for a small subset, these 3 of 100 and however many, or do you think that in some patients the IgG clone dissipates and then you're left with the IgG4 alone?
Well, although we found MuSK-specific IgA only in a subset of patients, we have to think about the fact that these IgA actually dominate mucosal sites. So it's also possible that we are underestimating the real prevalence of MuSK IgA. And then thinking about the connection of MuSK-specific IgA and IgG4 B-cell clones, yes, that's a very valid point. However, let's think, for example, that an IgA B-cell can class switch to IgG4. That could be possible. However, the IgA B-cell can have more affinity for bacteria, while the IgG4 can have more affinity to MuSK. So looking at the IgA can actually be a good way in order to find the bacterium. But as I said before, the very first part of the project is doing single-cell transcriptomics. So if we isolate, and we actually had some data, IgA B cells, we can actually look at their transcriptome. And although those cells are still IgA, if they are prone to IgG4 class switching, they will produce the so-called stereo transcripts that basically will predict a class switching event towards IgG4. So studying the characteristic, the genomic characteristic of the IgA B cells can actually give invaluable information for the production later of IgG4 antibodies.
But would these IgG4 antibodies from the switch still bind to the same epitope?
We don't know. It's also possible that these IgG4 antibodies could actually lose their affinity for the bacteria and have more affinity for MuSK. Another characteristic that I have to mention, though, is that these IgG4 antibodies are quite intriguing because they undergo the so-called Fab-arm exchange. So when we think about an antibody, each arm will bind as the same antigen. In the case of MuSK IgG4, instead, only one arm will bind MuSK, while the other arm will bind a different antigen. And so it's also possible that an IgA and the IgG4 can actually have different affinity and binding strength to different antigens.
Thanks, Gianvito. Great presentation. Again, it's probably a naive question, but why the gut flora? Why not, say, respiratory flora? And why limited to bacteria? Why not other microbes?
Yeah, we actually took inspiration from different examples in the literature, and obviously we are considering the fact that although bacteria could be a good target, maybe for example viruses or fungi could be also too. And again, if we think about, however, one of the common site where bacteria reside is actually the gut, with a higher prevalence of bacteria. And the other fact is that the IgA autoantibodies actually represent the most abundant immunoglobulin produced in the body, and they're mostly found in the gut as well. So we think that the gut could have a role. In terms of if bacteria or viruses, fungi, obviously this is a very, important question. But obviously this has never been explored in the past. So IgA autoantibodies of MuSK myasthenia have never been found. We have an assay that can detect them. So we're going to start from bacteria. If we don't find anything there, we're going to move to viruses as well.
Can you talk through how you're going to use the funds in your budget exactly, and how many samples you anticipate being able to analyze, et cetera?
And if there's contingency to move to non-bacteria within that 10,000?
Yeah, right. Because we already have made some progress in the IgA B cell cloning, so we have this IgA tool, we're going to use the budget for the IgA sequencing technology. So this technology involves the incubation of this large bacterial library with the antibodies. Then we're going to use flow cytometry. So most of the budget will be used to purchase and support the cost of flow cytometry antibodies, the bacterial cell sorting, and then the sequencing of the bacteria that is bound by the antibody. So basically, we're going to leverage the so-called 16S ribosome RNA sequencing. This is a gene that is conserved in all bacteria. Because of variability between bacteria, sequencing this gene can also give information about the species that we're looking at. And so we're going to use the budget for that. And given the fact that we already have some IgA monoclonal autoantibodies, we're actually working, right now, we have a collaboration with Dr. Noah Palm at Yale that works on microbiota. And so as soon as we get the funding, we can use the funding in order to do the experiment right away.
I think we can take a couple of questions from the floor.
Thank you very much. It's very, very nice presentation. I have a couple of questions or comments for your consideration. One is, I was surprised that you found IgA antibodies in certain patients, regardless duration of disease or treatments or so. Seems that is patient-orientated or so, depending on the patient and not the disease itself. And the other is more a comment. How do you think you incorporate these in the fact that we know that MuSK myasthenia has a very significant geographic distribution, very different from the AChR antibody disease you find in certain populations, certain geographic areas, and racial distribution as well. It's not in every race or ethnicity. How do you think about these together?
Yeah, yes, it's true. We didn't find a specific correlation between the presence of IgA autoantibodies, disease length, and severity. For example, we have a patient with a follow-up of 11 years, and we found that this IgA response was long-lasting for 6 years. And despite the fact that rituximab was given, the IgG4 titer went down, the IgG8 titer instead, was actually quite stable. Regarding the connection between the masked myasthenia gravis and the geographical distribution, yeah, you're right. That's actually a very intriguing aspect that, coming from Italy, I've thought about that quite a lot. And we know that there are like some genetic predispositions in terms, for example, of antigen presentation, the HLA class 2, the R14, 16, DQ5. So it's also possible that the way a specific antigen, for example, is presented can like trigger an immune response in selected individuals. Obviously, I don't think that we have like all the answers right now, but because if we can like start putting like all the pieces of the puzzle together, I think we can advance and maybe come up with unifying hypothesis that can link, for example, the production of IgA and IgG4, and also give other insights in other diseases that are like dominated by IgG4. Think about autoimmune nodopathies, for example, or pemphigus in the dermatology field, or if we look at like the central nervous system, LJ1 encephalitis or Caspar-2 encephalitis. So, I think that could be a unifying factor that connect all these diseases, and I'm happy to explore it.
Yeah, I think we have only one more question because we're approaching the...
Okay. So sorry if I kind of missed what you might have already explained already. Are you just testing those 4 patients that have the MuSK IgA positive B cells? You're just going to look at 4 patients?
So we are going to start from 4 patients because those patients had the highest titer of IgA in the serum. This does not mean that other patients could actually mount an IgA response that is actually more prevalent in the gut. And the fact, yes, we are starting from 4 patients, but it's also true that when you look at the B cell repertoire from each patient, you can actually generate more than one specific IgA monoclonal antibodies. So overall, actually, we are working on a library of more than 10 IgA monoclonals, and we're going to use those 10 monoclonals against a bacterial library that our collaborator has collected over the course of the past years.
And you've got quite big sample sizes, have you? As in, for each individual aliquot, you've got lots of cells, because as you say, they're really rare,
Yeah, right. Actually, obviously, the number of cells depends on, treatment, for example. So it's very hard to give an exact number for each patient. But because we also have longitudinal samples from the same patient, we can actually look at different time points. And the fact that, for example, we find a specific IgA clone that binds to MuSK in one time point, if we look at another time point, we can find a different B cell. And putting all these B cells together, we're going to have some tools to explore the gut microbiota interactions.
Great. Well, that was a great presentation. Thank you very much, Dr. Masi.
Thank you.
The next presentation by Dr. Agradi from Italy, Fluctuations in Liver and Renal Function Test in Myotonic Dystrophy Type 1.
So hi everyone, and thank you Sharks for the opportunity to present my project today. So let's start with the background.
Buongiorno. Allora, in settimana quindi ha fatto la seconda infusione di farmaco. Ha avuto qualche disturbo negli scorsi giorni? No, sto bene. Perfetto, anche se come può vedere agli esami di controllo è emerso che ci sono le aste e le alte sono un pochettino più alti rispetto a come dovrebbero essere. A parte questo non abbiamo riscontrato particolari problemi. C'è qualche problema sul farmaco? Non possiamo essere sicuri che non sia un effetto legato al farmaco, quindi le faremo comunque ripetere gli esami del sangue per precauzione. Ok, grazie dottoressa.
Sarebbe molto utile avere a disposizione dei dati sulle fluttuazioni degli esami del sangue raccolti in maniera sistematica.
So what we know about lab abnormalities in DM1 so far is that they are often reported in the literature, but actually knowledge about exact frequency, clinical correlations, and longitudinal course is still scanty and debated in this field. So at NEMO Clinical Center, we decided to retrospectively analyze lab data of patients with DM1 collected between 2013 and to 2023 for a total of 1,043 ratings from 100 patients. So we confirmed what is described in the literature. So they have a high rate of lab abnormalities. And here you can see in blue the values above normal range, and in yellow the values below normal range. And we also found a high rate of lab fluctuations in our cohort. So here I focused on liver and kidney exams, because according to the latest report of FDA, they account for the vast majority of exclusion criteria for clinical trials. So you can see that the alterated values, for example, for liver function, they are between the upper limit of normal and 2 or maximum 3 times the upper limit of normal. So they are in the lower range. So, coming to the objectives, we want to verify blood test abnormalities and fluctuations in a larger cohort in a prospective multi-center study. We want to determine the degree of these abnormalities above or below normal range. And finally, and most importantly, we want to look for association with the liver and kidney involvement that could be useful for changing in clinical practice and potentially care recommendations. So this is a multi-center pilot study with 5 different time points. At screening, patients with known active disease or cancer, chronic medications, and alcohol abuse will be ruled out. The selected patients at baseline will undergo routine and additional blood tests, as you can see here, plus instrumental tests, which will be abdominal and urinary tract ultrasound scan. At months 6 and 12, they will have an on-site visit with medical history revision and routine blood tests. And if any abnormality is found, they will undergo additional tests as needed. We will do the same remotely at months 3 and 9, and at every time point we will call the patients on phone to tell them how to behave before the lab tests are taken. By year 1, we think that we will be able to enroll 90 patients, and 1.5 years after baseline, we will have the database lock and statistical analysis. So, what's the money for? Nemo Clinical Center will be the coordinator center, with Manchester and Sheffield being the satellite ones. Each center will have a data manager, which will be in charge of patient management, data collection, and data entry in a common and shared REDCap. And the funding will be divided, as you can see here. So we will cover the pay for 6 months of a data manager per center, and also the setup of a common REDCap. So what we expect is that expanding the knowledge about lab abnormalities and fluctuations in DM1 will provide better interpretation of safety values, which is of particular importance in the era of pharmacological trials, better distinction between clinically significant and non-significant values, and potentially the definition of new management algorithms. So, for example, I hypothesized this for the liver function exams. So for us, it's important that clinicians know when to adopt a watch and wait approach, or when to ask for additional tests, or when to consider an expert consult. So thank you for your attention, and now, Sharks, it's up to you to help us give an answer to Mr. Rossi and to our team as well.
Great. Thank you. Well, I will open this to the Sharks, and I think no one has expertise in this specific area. I did not prepare for it, so probably I will rely and count on the common sense of the Sharks and the audience.
I can try.
Yeah.
I'm a little bit confused. Are you trying to establish, be able to answer the question of eligibility to clinical trial, or are you trying to determine the extent of the multisystemic involvement in myotonic dystrophy type 1?
It would be useful for both, so we don't have so many safety data about the lab values, so I had a review of the literature which is available, and actually we lack longitudinal data. So for example, there are studies about liver function, kidney function, and metabolic syndrome, but the data were collected retrospectively or maybe just one time, so they had just a single point evaluation. So we want to clarify and confirm the lab abnormalities to better understand if there is any clinical correlation with organ impairment, and that could be useful to give answers to patients and also to, when the patients come and have an IV infusion for clinical trials, to be convinced that what we see in the lab fluctuations and alterations is something that is linked to the pathology, so to DM1 and not to liver impairment due to the drug. So
I understand that, but in the, if you're trying to establish eligibility for clinical trial, even if you know the fluctuation of the lab result, you may end up still doing a serial evaluation in a certain patient to make sure if for that particular patient, if this is a problem with the drug or just due to disease progression.
Yeah, that's
so how would like having this information actually help you going back to the patient and establishing?
What we want to do is to design a kind of an algorithm to know what to do to better address the problem that we are facing. So, for example, if we found an alteration that is above the upper limit of normal but below 2 times the upper limit of normal, I know that I have time to reflect about it, and I can just tell the patients to redo the exams in 3 months, for example. But if I see alterations that are above that value, I need to investigate further. So, and we also need to understand the exact time points to take the examinations. That's why we decided we chose a small period between one evaluation and the next one, so 3 months, because we want to see if there are fluctuations that are due to the disease and not to a liver problem or an evolution of a clinical problem.
So I get the relevance of what you're trying to do. I think you've explained it well. Can you explain how this is different from your existing data set? I think I know, but you've got 100 patients with 1,043 lab ratings. So what's different between that data set and what you're proposing here?
So the one I was, So first of all, the data I presented to you are retrospectively collected. So we lack clinical correlations. So we just have the lab tests, but we have no idea of the correlations with underneath organ impairment. And we also want to have a standardized protocol, so all the patients are taking the tests at defined time points, and they are all doing the same additional tests and instrumental tests.
But those data still give you idea about short-term variability in these specific tests.
Yeah.
So the other question I have is just how this will actually roll out, right? So a patient in Sheffield comes in and they have an AST of 1.5 times the upper limit of normal. What happens then?
So, I think that our units are different in Italy. So we, our biostatistician will standardize the measures so that we can confront the data and be aligned on that. And so if you want, I can go back to the slide to show you the additional tests that we planned.
No, I guess where I'm going is there a standard approach to managing that in terms of the other tests that you would do, or is it left up to the investigator?
Yes, that would be the standard of care. So I had a conversation with a friend of mine who is a general physician and with an interest in pathologic diseases and also GI diseases. And so we will follow the standard of care with the exams I wrote on this.
So you're harmonizing standard of care, so you'll all
Yes.
be behaving the same,
Yes,
and then you're creating a normalized, normative
but
value.
The objective is also to see if the standard of care is a standard of care also for DM1 patients. So potentially we could make some changes or to improve also the standard of care for these patients.
And can you talk more about the targeted tests?
Yes, of course, if you want. Oh yes, you need to. Okay, it's fine. So I decided to focus on liver and kidney function for the reasons I told you. And so we will have, firstly, additional blood tests, so to assess liver function in terms of necrosis and also to screen out for hepatitis, which accounts for the vast majority of AST and ALT augmentation. And for the going to the instrumental test, for example, they will have an abdominal ultrasound scan to look for fatty liver disease, which accounts also for the vast majority of alterations. And that's it for the further tests for liver function. When it comes to kidney, it's a little bit more difficult because it's difficult to investigate about kidney function in a very initial phase because the exams tend to be abnormal in further phases, but we would like to do a 24-hour urine collection and also see if we can assess the cystatin C. We can do that in Milan, and so that's something that we can use to confront with creatinine, because you know that one is a problem in neuromuscular diseases because it tends to be lower than it should be.
And these are all standard of care tests?
Yes.
Do you have any concerns about the feasibility of patients coming in every 3 months for the test? And is that standard of care in your institution?
So it's not standards of care to see the patients every 3 months. That's why at time points 3 and 9, we planned to see the patients just with a video or a call. So that will be done remotely. And that's also why we planned to do just the routine blood tests, because the other tests will not be covered by the healthcare system or rare diseases exemption.
Dr. Lilker, I know you are not supposed to grade, but probably you know the points of strength and weaknesses of this study more than anyone else. So do you mind commenting on this?
Before you do that, can I just ask about CK? I didn't see CK. Does that mean that it's already measured, so you don't have to remeasure it?
No, we are measuring the CK, yes.
With, sequentially?
Yes, at every time point, yes, of course.
And sharks have free will, so if you want to open it up to the audience to ask your questions, you can too.
Thank you. I think that might be. But maybe you could just give us an outline of what you see for the future, and if you win the prize and the project gets going, what will be your next steps?
Yes, of course. So this is a pilot study. We plan to enroll only 30 patients per center, which is a lot if we think that it's a standardized protocol followed by everyone, but it's not enough to confirm the data in a larger population, so it would be very useful to confirm the data in more patients, and also to expand the inclusion criteria, because as you can see, they are quite strict now, so no chronic medication, no alcohol abuse, no chronic disease. It would be useful to assess the same things also in patients that have maybe chronic diseases or they take medications, but that's something that needs much more funding and organization. So.
You mentioned that chronic medications are an exclusion. Can you describe that a little more? And are these patients on mexiletine? Is that excluded? What would be the effect of mexiletine on your data?
Yes, also the being on mexiletine will be an exclusion criteria. Actually, we have many patients in Italy that take mexiletine, but we also have at Nemo Clinical Center specifically many patients coming for first evaluations, and they are drug-free. And actually what we tended to do in the previous year was to give mexiletine to patients because it was the only medication we had. Now that the panorama is expanding, I think that we can go further with patients to understand the real benefits of mexiletine and take it out if we think that it's not so necessary, and give them the opportunity to take part in clinical trials.
Yeah, I think we can have a couple of questions from the floor. We have 3 more minutes. Emma?
So, as this is a pilot, once a year, if you have like abnormalities or alterations are described in the disease, in Italy it will be covered. So just the ultrasound scan for liver, abdominal. Yes, it will be covered because they also have an exemption for rare diseases. And so, yes, we have many problems, but the healthcare system is quite present.
We could make it work.
Think careful about the answer.
As a community-based neurologist, I'm often called to see patients in the hospital who are weak. Invariably, since it doesn't seem to be in the hospital's best interest to ambulate patients anymore, it's often on the day of discharge that they call me to see why the patient's weak. And these patients often have gastrointestinal, GI consultations, hepatitis workups, because their LFTs are elevated. And they have polymyositis because ALT, AST, LDH are released from muscle that's degenerating. How are you going to distinguish these LFTs, with the exception of gamma GTP, of course? How will you distinguish these LFTs that may represent muscle disease as opposed to liver disease? The question about CK from the shark is absolutely pertinent, because if you don't correlate your LFTs with the CK, you don't know where it's coming from.
Yeah, actually, I hope to have an answer in a year if I'll get the funds from the sharks, because that's the point of doing this research. So I hope that we'll have an answer.
It's measuring 3 other enzymes that do not exist in the muscle, the alkaline phosphatase and the GGT and another enzyme. So probably that's why they are measuring these 3 enzymes.
Yes, we have the additional tests to trying to discriminate between what comes from the muscle and what comes from liver and metabolic disease. So that's the point of all those additional tests.
And DM1 can actually have involvement of the hepatocyte by itself as well as systemic disease. So doing the ultrasound is going to be important. They can have fatty liver, for example.
Yes.
That can be the reason for the AST.
Yes, that would be useful also to look for potential new techniques, because it's also described alterations in canalicules contraction.
Yes, the bile duct.
Yes, but that's quite difficult to assess in a pilot study, so we'll think about that later.
Great. I think that was a great presentation. Thank you very much.
Thank you.
The next and the last presentation is by Dr. Zara from Oxford. Efficacy and safety of low dose of anti-CD20 therapy for new onset acetylcholine receptor antibody positive myasthenia in older patients.
So good morning, everyone. Thanks for the invitation, and thanks to the Sharks for this opportunity. So the age distribution of myasthenia gravis has always been bimodal. However, in over the last 30 years, the number of patients with the late onset and very late onset myasthenia gravis increased significantly. And managing patients with very late onset myasthenia gravis can be particularly challenging, as they can experience a potential severe disease, they can have comorbidities, and so they often require long-term immunosuppressive therapy and high dose of steroids, which can lead to adverse effects and worse comorbidities. In the last years, new target treatments have become available for severe and refractory myasthenia, and among these, one of the first was rituximab, an anti-CD20, which have been used for nearly 20 years. And since then, several case reports and case series have been published with the modest and controversial results, as they include patients with refractory disease and long-term disease duration. And first trials have been published in 2022, the BEAT-MG, which confirmed that in patients with refractory disease and long-term disease duration, rituximab is not effective. And in contrast, the RINAMAX study, which demonstrated for the first time that small doses of rituximab are effective in patients with short disease duration. So starting from this, we wonder whether if you can use anti-CD20 therapy as a first line in a very late onset myasthenia, and if can a single dose of anti-CD20 change the disease course when administered first line, reduce the need of additional therapies, be safe in very late onset myasthenia gravis, and have a positive financial impact in management of myasthenia. And the aim of this study, the specific aim, is to assess the efficacy, safety, steroid-sparing effect, and the financial impact of a single low-dose 200 milligrams of anti-CD20 within 12 months from disease onset in immunotherapy-naive patients with non-thymomatous very late-onset AChR myasthenia. And how are we going to do this? We will treat patients with mild or moderate myasthenia. After clinical assessment, we will treat them with corticosteroids and then anti-CD20, and we will assess them at 3 months, 6 months, and 12 months. Then we will treat patients with severe myasthenia gravis, and the protocol will be basically the same, but we will administer also rescue therapy before starting with rituximab. And then we will assess the patient, clinically assess the patient with the myasthenia gravis scales. And as a control group, we have plenty of patients, data of patients matched for age, sex, disease severity, treated with standard care. And we'll expect disease remission or minimal manifestations, reduce the need for additional immunotherapies admissions, improve health and quality of life, and reduce costs. Then, next step, if successful, we would like to extend the follow-up, expand the treatment cohort, including thymomatous myasthenia and early onset myasthenia. And how could the grant help? It will contribute to fund a young clinician in order to recruit and assess patients throughout the study, and to support with the study design and the statistical analysis. Thanks for the attention.
Thank you for the presentation. So very ambitious project. Can you summarize how the study is different from RINAMAX, and how those differences would add to the literature?
Yeah, first of all, we are trying to treat patients with a smaller dose of rituximab, not 500 milligrams, but 200 milligrams, because there are some studies from the rheumatology field which demonstrated that lower doses of rituximab are effective as well, and small doses are associated with a low risk of adverse effects. And then we are focusing just on very late onset myasthenia gravis, and we are planning to recruit between 10 and 20 patients per year. So it's ambitious because we want to have a large cohort to study, and we would like to evaluate the disease-modifying effect of rituximab in long-term.
And how are you defining very late onset myasthenia?
Yeah, there are patients that are older than 65 years old.
I see. And, you know, the average age of patients in the RINAMAX trial was 65, you know, with obviously some variation. Do you think that that age cutoff makes sense for your clinical question to add to our scope of how we would use rituximab?
Yeah, because patients with very late onset are nowadays the majority of patients, and so they frequently need a long-term a long-term immunosuppression with other immunosuppressive treatments, and we think that just with a small dose, with a few cycles of rituximab, we will able to treat these patients.
And I'm sorry if I didn't understand, but are these patients going to be on, you mentioned rescue therapy first in the moderate to severe disease, but otherwise are these patients going to be treated, per standard of care with other therapies, or how are you envisioning monotherapy versus in combination?
No, we're just thinking to treat our patients just with rituximab and corticosteroids, and if they need rescue therapy, we will give them IVIG or Plex.
Go ahead. You sure? Great presentation. Thanks, Pietro.
Yeah, I was being the nurse shark. Is that the nice shark? You go first.
Thank you. You said we were going to disagree with each other before we started. But this is all very collegiate so far. Just about the depth of B cell depletion from a very low dose. Will you be monitoring that? And are you sort of sure from the other literature you mentioned that it will be sufficient, or is that the question you're trying to answer here?
Yeah, there are just a few case reports and a small case series, so we need more. We need other studies to be sure that small doses are effective and they can deplete B cells. But we have already a few patients treated with small doses of rituximab with a short follow-up time, 1 year. And treated also with lower doses of rituximab, like 100 milligrams, and they are still depleted after 6 months. Yeah.
And as was mentioned before, it's quite ambitious. And in terms of the budget, do you have funding from elsewhere for, say, drug costs, excess treatment costs, and other things? Is there money coming from other places to support this as well?
The treatment rituximab is provided by NHS, so we don't need any fund to pay the drug, just to help a fellow to assess the patients and to collect clinical data and to help us with the statistical analysis.
And is the fellow you, or this is an additional?
Yeah.
Is you? Okay.
I think that's the whole point.
Just wanted to check. And then just a final sort of cheeky question. So what's clear at this conference is that I think we treat myasthenia quite different from the US in the UK, and use more rituximab and complement and FcRn and other things haven't really entered the landscape so much. So where do you is this still relevant? Where does this sit in terms of the other options that are now available and have been used increasingly in other healthcare systems?
Sorry, can you repeat? I didn't catch.
I guess what's the value of continuing to study rituximab when we already have some evidence it works, and we know that there's also other options now that we could use instead?
Yeah, there are also new drugs, new target drugs, but they are really expensive. And we think that is needed to have another treatment, an alternative like rituximab. It is cheaper and it could be effective as well.
Yeah, thank you.
So the NHS will pay for rituximab as first-line therapy for new onset myasthenia gravis?
Yeah, we are trying. We have an agreement. And we are starting to treat patients with rituximab as a first-line therapy.
So you said trying. Do you have any concern?
No, we have an agreement, and we are starting, okay. Yes.
That's cool. Yeah. That's great. If you'd like to experience prior authorization, we'd be happy to. I have a question about the historical controls. Can you tell us more about them? And I guess my particular concern is patients in a clinical trial are treated differently. And as I understand it, you're going to allow patients in this study to have their steroids managed as per protocol. Do you have concerns that the behavior in the trial regarding other medical management of myasthenia might differ from the historical controls?
Yeah, the two cohorts are really different because our historical patients were treated with different kind of drugs, and our intention is to treat patients that are naive patients. So they are naive, and so it's quite difficult to compare the two cohorts, but it's not like a clinical trial, but it's more a clinical study. And so, yeah.
So the cohort will be previously seen patients, treatment naive, who are not given rituximab.
Sorry?
So the cohort would be treatment naive patients in your center who were not given first-line rituximab.
Sorry.
I think I get it. Yeah.
So I'm going to go back to the RhinoMax study. And in that study, we do know that rituximab at 500, which already is a low dose, works for the patient that, I mean, that study was a little imbalanced, and the treatment group patient, the mean age was 67. So we do know that already that in patients of about 67 years old can respond positively to 500 milligram prednisone of rituximab. So why not study it in patients older than that? Because there is we don't know about that. There is a gap of knowledge there, rather than doing a lower dose in the same population.
Yeah, we are also going to enroll patients, so patients older than 65, and so we would like to enroll also patients older.
Limited to patients over like the age of 70, for example, and not study the ones that have been studied already.
Yeah, yeah, it's a good suggestion, and I think that RhinoMax study, another difference between the RhinoMax study is that RhinoMax was just 1 year study, and we would like to go further and to see if these patients stay well with the small dose of rituximab.
Chip, do you have any? Seems that you're thinking about a question.
Yeah.
Just 2 points. One is how your entry criteria is new onset disease less than 1 year. How can you be sure that those individuals who are at the upper end of that duration truly have disease less than 1 year? And why not shorten it down to those who you have historical evidence of 6 months or 3 months of disease? The RhinoMax study was done with less than a year. The concern is that disease duration beyond 1 year, patients may not be responsive. And so I have concerns that if you use a broad range of entry, that you are going to be including patients who have disease duration more than a year that may mess up the study. The second thing I had is I heard you say patients will be treated with prednisone and rituximab. Is that true?
Yeah.
So then I do have concerns on how that prednisone is going to be managed. Prednisone has screwed up every myasthenic trial we have tried to run. Mycophenolate, methotrexate, the BeatMG rituximab trial. And so I really have concerns, unless that is controlled or unchanged at a much lower dose, it too will alter the results of your study and may confound everything.
Yeah, that's a good point. And our intention is to see if they are able to wean off the corticosteroids within 3 or 6 months after starting rituximab. And also will be interesting after this preliminary study to extend the study for patients with a longer history of disease, like 2 years, 3 years, and to see what happened.
Okay, we still have some, Emma?
I'm still a little confused about if this is a clinical trial. Are patients going to be consented? Where is the budget? I mean, you're using, I mean, $10,000 is nothing, right? If it's, I understand that the NIH might provide the drug, but is this a clinical trial design or?
No, it's not a clinical trial.
It's a real life. We're going to do this and follow them prospectively and see what happens.
Yeah, it's a real life study. Yeah, it's not a clinical trial.
No control.
And you're going to compare with the natural cohort?
No, we are going just to compare with the data of patients treated with standard care.
Yeah, so there is really no control group.
Yeah.
Okay.
Historical control.
Yeah, but not at this dose. You're using a very different dose that has never been used before.
I think the historical controls are patients who weren't treated with rituximab. That was the question.
No, patients treated with the other treatments.
Right, so historical controls not on rituximab.
Yeah, but how can you compare? And also this is a low dose rituximab. So.
That's a problem. Valeria?
Yeah, just a quick question. I probably already know the answer, but just to make sure. Given the type of study with the drug that's out there, did you talk to the pharma to ask for funding to try a lower dose in the patients? I mean, what's the interaction with the pharma looking at the drug at a lower dose? Did you seek their consultation or help maybe there?
No, we didn't have any interaction with pharma.
I think in the B-cell therapies are generic now in the UK, so there's actually very little interest from pharma.
You know, the dose of rituximab in myasthenia studies is based on a lymphoma protocol or rheumatoid arthritis protocol, and both are arbitrary. So we really don't know how they have chosen this dose. But my question to you is that if rituximab has not been shown to be clearly effective at a larger dose in a couple of at least good trials, why do you think at a lower dose it would work? And why did not you choose MuSK instead of acetylcholine receptor myasthenia?
Because we are going to select just patients with a short disease duration disease, and other studies show that rituximab is effective in patients with a short duration disease. Studies in which rituximab failed were studies in which patients had more refractory disease and long-term disease duration.
I think we still have 1 or 2 minutes if you want to.
I've got a question. Over here.
Oh, over there.
Side.
Katie.
I've got 2 actually. So first of all, what's your primary outcome measure?
It's an improvement in the MG scales, MG-ADL, and also steroid-sparing effect.
So both. And are you going to analyze that on a per protocol or an intention to treat sort of thing? Because, you know, with rescue therapy, then it starts to get muddy, doesn't it, when you've got improvements in the severity scores, but they've relapsed and they've had some other treatment.
Sorry?
So are you going to analyze that? Are you going to include those that have rescue therapy in your analysis?
Yeah, we're going also to include patients were treated with the rescue therapy, IVIG or Plex if needed.
Yeah, because I think that was probably one of the problems with BTMG was that, you know, the severity scores improved because they've had to have rescue therapy. And you mentioned one of your aims was about seeing if it improves cost. How are you going to measure that? No,
we don't have an idea, but in the rituximab compared to other new treatments is cheaper. So we are confident that we are going to reduce the cost.
Okay, so you're not going to do a sort of cost analysis?
You have a question? That's great. I think we have done a great job regarding the timelines, and we have satisfied all the requirements with extensive discussion. Thank you very much. That was very good. The sharks are going to meet and grade, and we will announce the results at 12:30 here, I think.
So we're already down to the final session of this great meeting. And this is a session on artificial intelligence. And without further ado, I'm going to announce the first speaker. That is Damiano Zanotti from the Stevens Institute of Technology, who will talk about AI-enhanced insoles for accurate kinematic and kinematic gait monitoring in SMA and Duchenne's.
Thank you for the introduction. Good morning, everyone. I'm excited to be here to speak about our recent work on machine learning models to improve the accuracy of instrumented insoles for gait monitoring in SMA and DMD. So the availability of new disease-modifying treatments for several neuromuscular conditions have created an urgent need for more sensitive, scalable, and affordable tools to evaluate the effectiveness of these new treatments, especially as related to motor performance and ambulatory performance. Unfortunately, the conventional gait assessments that are available can only capture a snapshot of a person's physical condition, and those snapshots do not necessarily reflect well real-world performance. On the other hand, wearable devices have the potential to capture sensitive and objective metrics of daily performance, which we indicate as digital mobility outcomes, or DMOs. And the adoption of these DMOs in clinical research can potentially reduce the cost of future clinical trials by reducing the target enrollment and by shortening the duration of those trials through the adoption of more sensitive outcome measures. So it is not surprising that consumer-level wearable devices, such as the wrist-worn activity trackers, are increasingly being used in clinical research. However, those devices have so far demonstrated poor accuracy, even when we use them to detect basic parameters of mobilities, such as step count or distance walked per day. And they tend to perform even worse with slow walking individuals. And this poor accuracy is a big problem in clinical research because it might prevent the detection of subtle but clinically meaningful changes in gait pattern that can reflect, that might reflect a positive response to a treatment. Research-level devices, on the other hand, are more accurate, and among the different types of wearable devices that are available in the market, we believe that instrumented insoles stand out for their ability to measure both spatial temporal and kinetic parameters, which is not possible with other types of compact wearable devices, such as ankle or foot-attached gait monitoring. However, the conventional data processing algorithm that comes with the off-the-shelf smart insoles that are in the market has so far demonstrated only moderate accuracy. And so our work in the last 10 years or so has focused on developing new machine learning models to improve the accuracy of these smart insoles. Here we show our latest prototype, which we call the AI Sole. It consists of a pair of insoles instrumented with motion and pressure sensors and a companion phone app. The uniqueness of this technology lies in machine learning models that allow us to significantly reduce measurement errors by leveraging a data set of gait data collected by a large set of individuals. And by using this algorithm, the device can measure a rich set of spatial temporal gait parameters that pertains to different domains of gait, as well as more conventional volume parameters. And it can do so with high accuracy, despite relying on affordable sensors. So in the rest of my presentation, I will first cover 3 studies that we carried out to validate our machine learning models in walking tasks that progressively became more realistic and everyday-like. And then I will talk about a pilot clinical study that we carry out, which highlights the potential clinical utility of this technology. So in this first test, we asked a group of healthy individuals to walk and run on a treadmill at different speeds, while their gait patterns were measured by our insole technology and by a camera system that we use as a reference to evaluate measurement errors in the insoles. Here we developed 2 types of machine learning models, both based on support vector regression, or SVR, a generic type of model, which does not require any reference data to be collected from each individual user, and a subject-specific model, which is a model that is fine-tuned to each individual user based on reference data collected with the camera system. So we found excellent level of agreement between the insole metric measured with both these models and the reference system. However, the study also highlighted that the subject-specific model consistently outperformed the generic model in terms of mean absolute error, or MAA. And this indicates the importance of having subject-specific calibration data to reduce measurement error to a farther extent than what can be achieved by a generic model. But what if we don't have access to subject-specific data because it is too time-consuming or too expensive to have each study participant tested in a gait lab before we start a clinical study? And so to answer this question, we conducted a new study, this time with a group of 95 older adults. We asked them to complete the 6-minute walk test using our smart footwear. And in this case, we use a validated electronic walkway as the reference system to measure, to evaluate measurement errors. Here I'm showing the mean absolute errors for a set of 4 gait parameters. So the shorter those bars are, the better. Each pair of bars indicate a different data processing algorithm, and the 2 colors indicate whether or not the subject used an assisted device to complete the 6-minute walk test. So the red boxes indicate the errors that we obtain when we apply the conventional data processing method, and those are the algorithms that you typically find in smart insoles in the market, as well as in ankle and foot attached gait monitoring systems. And you can see that those errors are quite large. The green boxes indicate the error that we obtain when we apply our subject-specific models. So as I mentioned before, those models are very accurate, but they have limited practical value because they require a specific calibration from each individual user. So here we introduce a new type of model based on the transductive learning framework, which allows us to personalize the calibration models without relying on subject-specific calibration data, but instead by leveraging an existing database of gait data. And by using this trick, we were able to reduce errors in stride velocity and stride length by 42% compared to the conventional method, and the errors in swing time and double support time were reduced by 34%, again, compared to the conventional method. So those results are encouraging. They show that the machine learning models can work well in straight walking, even when we do not have access to subject-specific calibration data, but how well do they perform in realistic walking tasks? So to answer the questions, we run a third study when we ask a group of individuals to perform a set of activities, first in a structured way, and then in an unstructured way where they could choose the sequence and the duration of each activity. Then on a separate day, we ask them to use our insoles for a minimum of 4 hours during their everyday activities. So the results here show that our machine learning models based on support vector regression, or SVR, which are shown here in green, consistently outperformed the conventional methods, and this was the case for all walking tasks and both for the structured and the unstructured test. And in particular, when we pulled together all the data from all the walking tasks, the mean absolute errors were below 3% and 3.6% for the structure and the unstructured condition, respectively. In the same study, we also look at how the location of the wearable sensor on the human body affect the accuracy with which those wearable devices can automatically detect activity of daily living. And we found that in order to study this, we trained 7 different classifiers, each corresponding to a different combination of 3 types of sensors. The sensors embedded on a wrist-worn tracker, the sensor embedded in a smartphone, which was located inside the front pocket in the patient's, in the subject's pants, and then the sensor embedded in our insoles. And we found that all the combination, all the classifiers that were trained using combination that included insole data consistently yielded an accuracy in excess of 95%. Conversely, the classifier that only rely on wrist-worn sensor perform as the worst one, both in unstructured condition and in free living condition. So this provides additional evidence that wrist-worn activity trackers are not that accurate in detecting physical activities. So next we wanted to use this technology to evaluate gait function in spinal muscular atrophy and Duchenne muscular dystrophy. So we asked a group of patients to perform 3 standardized clinical assessments, as well as a set of gait tasks that were, or walking tasks that were designed ad hoc to simulate real-world walking. And we also measure the strength on the major muscle groups in the lower extremity. So this one was a pilot clinical study that we carried out in collaboration with Dr. Jackie Montes and her team at Columbia University, as well as research collaborators at Stanford University and Boston Children's Hospital. So here I'm showing you the results of the validation from the spatial temporal parameter. So each cluster that you see here corresponds to a different walking tasks. The 2 colors indicate the 2 participant group, healthy controls in blue and the neuromuscular groups in green. And then the 2 tones, darker and lighter, within each color indicate the particular data processing algorithm that we use to process the data. So the conventional one is in darker color and our SVR models in a lighter color. We found that the machine learning models significantly reduce measurement errors compared to the conventional approach. This was irrespective of the walking task and the participant group. And so when we combine all the data together, we found that the mean absolute errors were below 2.3% for the healthy control groups and around 3.7% for the neuromuscular groups. Here I'm showing the results from the validation of the central pressure data. So what you see on the left are the 3 representative central pressure trajectories that we collected during the 6-minute walk test from 1 representative participant from each group. The blue lines indicates the reference data that we collected with the validated electronic walkway, and the red trajectories are the outputs that we measure with our insoles using a new type of deep learning method based on bidirectional long short-term memory networks. So the basic idea here is that by fusing together data from heterogeneous tensors embedded in the insoles, we were able to reduce measurement errors in the COP trajectory down to 0.6 centimeters in the mediolateral direction and around 1.5 centimeters in the anterior-posterior projection. You may also notice that those COP trajectory show a higher level of stripe-by-stripe variability for the neuromuscular groups compared to the healthy controls. And so to better analyze that variability, we computed those cyclogram plots, which show the path followed by the center of pressure during an entire gait cycle. And then we extracted 5 scalar metrics of variability from those cyclogram plots. And when we look at correlations between those 4 scalar measures of variability and well-established clinical assessments, we found that higher level of noise in those cyclogram plots were strongly correlated with poorer performances in the 6-minute walk test and higher level of fatigability for the SMA group. And for the DMD group, higher levels of noise in the cyclogram plots were strongly correlated with poorer performances in both the 6-minute walk distance and in the 10-meter walk run. So those results are encouraging because they show the ability of this COP-related metrics to capture disease-specific functional deficits, so fatigability in SMA and maximal velocity in the DMD group. And because maximal velocity has been used before in clinical research to characterize or evaluate functional disease progression in Duchenne, but kinetic parameters have been less explored to this purpose, here we wanted to study how kinetic parameter, namely the anterior posterior projection of the center of pressure that you see there, how this parameter compare to maximal velocity in terms of their ability to discriminate between DMD phenotypes, as well as in measuring disease severity. So we found that both maximal velocity and the anterior posterior projection of the center of pressure discriminated between the mild and the severe DMD subgroup. However, only the anterior posterior projection of the center of pressure was strongly correlated with both the knee extensor and the ankle plantar flexor strength, which was not the case for the maximal velocity. And so this kind of suggests the potential utility of these kinetic parameters as a functional biomarker of DMD. Lastly, we also use the stride-by-stride parameters measured by the insoles during the 6-minute walk test to characterize a pattern of fatigability in the SMA group. And so to do that, we segmented the gait data measured during the 6-minute walk test into 30-second sections. And then we run a linear mixed model analysis to study trends on those data, on each gait parameter. And we found that for both the mild and the severe SMA group, there was a significant decline in stride length and stride velocity and a significant reduction in the anterior posterior projection of the center of pressure, which was not observed in the control group. Additionally, those declining trends were significantly more pronounced for the severe subgroup compared to the mild subgroup. Also, the severe group demonstrated significant worsening in the double support time, as well as in the mediolateral projection of the center of pressure and in the asymmetry index of the cyclogram plots. So overall, we believe that the decline in stride length and stride velocity might be related to muscle weakness, whereas the worsening or the increase in double support time and the shortening in the anterior posterior projection of the center of pressure might indicate 2 different compensatory strategies, one related to improving dynamic stability, and the second one related to decreasing loading on the knee joint at initial contact. We are now embarking on a longitudinal study, again in collaboration with Dr. Jacqueline Montes and our group at Columbia. Here the plan is to monitor gait function in spinal muscular atrophy and Duchenne muscular dystrophy continuously for 2-month-long periods, 12 months apart from each other, using this technology. And here I'm showing you some preliminary data that we obtained from a 16-year-old boy with SMA. We use our insoles for 5 days in his everyday activities. So the top plots show the empirical distribution in 2 representative gait parameters, segmented by duration of the walking bouts. And the bottom plots show, for reference, corresponding empirical distributions that we obtain from a healthy control with comparable stature or height. So in addition to the clear difference in terms of volume of steps taken during those 5 days, and in addition to the clear difference in stride velocity and stride length, you can notice that there is a higher level of overlapping in the empirical distribution for the SMA participant compared to the control, which we believe is related to or indicates less versatility in modulating stride length and stride velocity in real-world environments. So to conclude, instrumented insoles can provide a rich set of spatial temporal and kinetic parameters with higher accuracy and granularity compared to other wearable technologies. By using machine learning models, we can improve the accuracy of those sensors without relying on subject-specific calibration data. And our pilot clinical test indicated that a subset of kinetic and spatial temporal parameters derived from the insoles are actually sensitive to functional disease severity in both Duchenne and spinal muscular atrophy. And those parameters can also differentiate between mild and severe subgroups in each population. In the future, our goal is to evaluate the kinematic properties of insole-derived metrics measured continuously in the real world, and then compare those properties with the kinematic properties of well-established clinical assessment test. And if successful, this research can potentially result in a new tool that can be used to evaluate the effectiveness of new treatments in terms of motor function and ambulatory function. With that, I thank you for your attention. I'll be happy to take any questions.
Thank you, Damiane. We have time for 1 or 2 questions. Seeing Valeria here.
Thank you, very nice, and there's lots of work there. So I was wondering, is this an alternative to the SV95, which is FDA and EMA approved already?
Yeah, so we believe that it's not just about stride velocity, right? There are other parameters that we can measure. The device can measure stride velocity just as commercially available devices, but it can also measure kinetic parameters in the real world with which other types of wearables cannot do.
I got that, but one thing you mentioned that was of use was that it was used to, the kinetic parameters are allowed to distinguish between the severity of DMD patients, if I got it right, which I don't think we need well, that was tell by clinical parameters. Mm-hmm. And also, the other thing is that the using this to assess the fatigability in the 6-minute walk test by splitting in the time frame of, first minutes, that's what's usually, that's normal to think about that, but so that can be done with the stride velocity or with other things. So my question is, it looks like this is adding things, but practically it's looking like, to me, it's looking like an alternative to what's already approved, but I'm sure I'm missing some
Thank you for
details.
the question. I think you're right. So those were data that we obtained from a pilot test, and the data were collected in controlled condition, simulated the real world conditions still in an indoor environment, except for the last slide that I show you. What we are going to do now with the support of the NIH is to bring this to the real world. So far as I know, no research has been done in terms of capturing kinetic parameters, center of pressure related parameters in the real world, meaning continuously during a real world ambulation over everyday's activities. And yes, definitely we will need to compare the kinematic properties, for example, the minimal detectable change, right, that has previously been documented for the 95 percentile stride velocity with our metrics. The kind of versatility of our technology is that we can measure both, right? And so we will be able, yes, after the end of this 4-year study, we'll be able to tell which one is more sensitive. And I'm sure that this will depend on the population as well, right? To answer your second question about SMA, yes, fatigability, pattern of fatigability have been measured before by looking at stride velocity and stride length. Typically, the conventional approach is to use the comparison between the first and the last minute. That's what my collaborator Jackie Montes has done in the past. Now we want to look at the trends with more granularity, and that was the reasoning for kind of splitting the stride-by-stride data into kind of smaller bins. The other advantage of using the wearable sensor is that you now can measure those gait parameters during the full set of 25 meters of the test, as opposed to just what can be possibly measured with an instrumental walkway, right?
So thanks you, Demi. I know we're out of time for questions, but people can talk to you at lunch. Thank you. So up next is Jasper Moreau from University College London, who will talk about AI tools and muscle MRI segmentation and diagnosis.
Thank you, and thank you to the organisers for inviting me, and it was a good strategy to put the most exciting topic last. It's good to see there's so many people here. So a couple of disclosures, and also there are some AI-generated images in this talk, but I will point those out to you. So what I'm going to cover today, first of all, is to think generally about using AI in image analysis, quickly talk about machine learning as a technique in diagnosis of myopathies, and then mainly focus on segmentation, why we segment muscles, and how we can now segment muscles using neural networks. So image analysis is a complex problem, and in fact, you'll all be familiar with these, and it was used for a long time as a way to distinguish humans from AI. I thought it was quite funny as well that when I was preparing this talk, they now do the kind of alternative text thing, and apparently this is an MRI of the brain, and I'm sure you can all see that in fact it's an MRI of two brains. Just very briefly to discuss some terms, AI itself, artificial intelligence, is a very broad and general term. It can mean anything that can be used to make a computer system act or behave like a human. More specifically, machine learning is a subset of AI where it uses repetitive learning through feedback loops to try and improve the system. Machine learning in general can involve human input. Deep learning effectively takes out the human and use multi-layered connected networks, often called a neural network because really it functions in a very similar way to the brain, as we'll discuss. Now, in terms of AI image analysis in medicine, AI you might think stands for artificial intelligence, but in actual fact, on this slide, it stands for avian intelligence. And there's a very good, interesting, I should say, study from 2015 where they used pigeons to interpret breast biopsy images as being cancerous or not. In actual fact, it's a good way to think about AI because the way we train AI is very similar to how these pigeons were trained. They were given the same image over and over again, a reward system, and believe it or not, within a few weeks, they could distinguish cancerous from benign slides with about an 80% accuracy. But in actual fact, if you combined 4 of them into a flock, they were 99% accurate. Someone asked the author, if the challenges can be overcome, will cancer diagnosis in the future involve giant server farms of birds pecking away at images? And the reply, which was quite prescient, was, I doubt it. I suspect that computers will get there first, which we'll be discussing today. And so again, just as an overview of machine learning, if we have an image like this one of a breast tissue, a biopsy, in ordinary machine learning, the human might decide the aspects of the image which are important, how purple it is, how pink it is, maybe the homogeneity of it, and then decide how those might link together, and ultimately, through positive and negative feedback, decide whether it's cancer or not. And through repetitive trials with different samples, that kind of the kind of relative weight and influence will be improved. Now, deep learning or neural networks is essentially the same process, except the entire thing happens in a black box. There's no kind of external input. You simply give it the images, and then the system kind of works it out itself. But underneath it, it's doing the same kind of things. But it can be quite difficult to know exactly what in the image is being learned. So what's needed for automated image analysis? Well, first of all, I think really importantly, you need a clear question. So again, if you ask a vague question, it's not going to work very well. The second thing you need is lots of samples, lots of images that you can analyze, because again, for it to learn, it needs a large data set. The third thing you need is that those samples need to be categorized. So in this case, with MRI images, they need to either have a diagnosis or have a segmentation that's been done. The fourth thing you need is a big computer. Actually, this is a very big computer, but not a very powerful computer, so you need a powerful computer. And the fifth thing you need is a lovely computer scientist. This is Baris Kamba, who works with us and has done all the kind of technical work on this project. Right, I'm just going to briefly divert to talk about machine learning and diagnosis of myopathies. This was a fantastic paper from about 4 years ago where they used a machine learning technique to diagnose muscular dystrophies based on the MRI appearance. They used almost 1,000 scans, that's the kind of number that you need, with 10 different genetically confirmed muscular dystrophies. The human actually did the Mercury grading of the different muscles, and then that Mercury grading was fed into the system. So it wasn't a pure AI technique, but the actual analysis of the pattern was done by the AI from the Mercury gradings. In actual fact, it was extremely effective. So again, very high accuracy, sensitivity, and specificity from the scans that were included in the model. You can see over 90%, sometimes 100% accuracy. I think what was most impressive is they then did 20 scans that weren't involved in the original model and tested the AI against 4 expert observers, 4 people who were quite bravely authors on this paper and pitted themselves against the machine. And interestingly, in that, on the left there is the software, got basically 19 out of 20, and far outperformed all of these supposedly expert observers. So again, it really does show you the value of AI. And of course, in most centers around the world, there isn't an expert observer to analyze the scans. So there's a real possibility here. Of course, what's missing here is that initially the scans were analyzed by humans to do the Mercury grading. But again, if we could automatically analyze the scans, the entire process could be automated. And so in the initial score of computer versus human experts, we have a computer scoring 1 and human scoring 0. So moving on now to segmentation. I guess the first question is, why do we want to segment muscles? And again, we've already heard yesterday that MRI can be a very responsive outcome measure in neuromuscular diseases. My PhD was in CMT and IBM, but it's been shown across a wide range of neuromuscular diseases. And of course, in order to get those numbers, you have to convert the image that's obtained, these are fat fraction maps, into numbers that you can then analyze, and that's why we need to segment. Now, of course, there comes a question, what to segment? Which muscles should we segment? How much of each muscle do we segment? Do we segment just a single cross-section or the entire length of the muscle? In actual fact, it's quite hard to answer these questions because to segment the entire muscle every single slice takes a very long time. And so up until this point, with manual segmentation, we've been predominantly doing a single slice analysis. There are many challenges to manual segmentation. As I've said, it's extremely time consuming. It takes about an hour to segment a single slice of the thigh and the calf, even longer if it's a patient with significant disease. It requires on the expertise of the observer, and unfortunately, it's not a very fun task, so it tends to be the people who do it for a length of time and then move on and do something else. And in some ways, therefore, it's an ideal task for AI, a repetitive task. But therefore, if you had large trials or long tertiary studies, you probably need multiple observers, which introduces inter-observer reliability. And again, the question is, how reliable are these human observers in terms of interscan, intra-observer, or intra-observer? So again, these things may be able to be improved with AI segmentation. A very brief diversion now, just to think about how we might assess segmentation quality. There are 2 basic options. You could assess it against the gold standard segmentation. For example, you could look at the results obtained by the gold standard segmentation, for example, with the muscle fat fraction or the area, and compare that with your new segmentation. Or there is this metric called the Sorensen-Dice coefficient, which is essentially a measure of overlap. So it goes from 0 being no overlap, 0.5 being 50% overlap, to 100 being complete overlap, which would suggest something's gone wrong if it's a perfect, if it's exactly the same. However, of course, like with any diagnostic test, if your gold standard, which might be manual segmentation, isn't perfect, it's quite nice to have a way to assess the segmentation independently of another standard. So in the case of muscle segmentation, this could be done by looking at interscan reliability at a short interval. It could be done by looking at the responsiveness of the results obtained in a longitudinal study. But ultimately, of course, the ultimate way to do it would be to look at the ability to detect treatment efficacy of your segmentation versus another method. We did look at this and published this year for a large group of manual segmenters and established some benchmarks of how reliable expert manually segmenters would be between each other. I'll just direct you to the bottom line, which is the inter-observer overlap. And for the thigh regions, it was a 0.92, and for the calf, about 0.94. That was the lower limit of what we would expect to be acceptable overlap, and we'll come back to that with the MRIs, with the AI segmentation. Perfect, so I'm now going to talk about muscle segmentation using neural networks. Introducing muscle sense. Yes, so this is one of the AI-generated images. We didn't have a logo, and I can assure you I didn't input into the Bing muscle surgimation. And that, of course, is one of the problems with AI. It can tend to hallucinate. So we developed this a few years ago based on a data set of about 170 scans that had been manually segmented with a wide range of neuromuscular diseases you can see there, as well as some controls. The technical details on the right-hand side for anyone who's interested. And here are some of the results. The top patient here is someone with IBM, who you can see quite severe. This is a fat image, this is a water image, and this is the fat fraction image. You can see quite severe involvement of the quadriceps, as you'd expect. The bottom patient is a CMT patient, where you can see quite severe involvement of medial gastrocnemius and peroneus. And despite this severe fatty infiltration, the AI is able to segment the muscles within the original boundaries. And indeed, we looked at the DICE coefficient of these versus the manual gold standard segmentation, and the values we obtained were well over the benchmarks for humans who had been trained by us. So again, already performing at the kind of level of a highly trained expert. And again, so the score, just to update you, computer 2, humans 0. But of course, beyond this, we could use the muscle sense and tried replicating previous analysis. So, for example, we previously looked at the retest reliability of fat fraction measurements in healthy controls, published this about 10 years ago, and we got an ICC values of 0.91 for the calf, 0.91 for the thigh and 0.89 for the calf. We did the same method with automated segmentation. We got the exact same ICC. But of course, because it was AI, we could do multiple slices. And so we extended to 5 slices. The ICC actually was much higher. And this is the advantage of AI. It allows you to do more in-depth or more detailed analyses in a shorter length of time. For those of you keeping track, the score is now computers 3, humans 0. I talked before about our paper in Lancet Neurology in IBM and CMT. And again, I won't go through in detail, but the graph on the left is the original publication. The graph on the right is the analysis repeated using automated segmentations, and essentially it's completely the same. And similarly, for the longitudinal analysis, the results are exactly the same. This is quite nice because, of course, it validates the AI segmentation, but also, I guess, validates how manual segmentation was unbiased. I'm going to give it a draw here, given the graphs look the same, although, of course, this is much quicker than the original segmentation. But, of course, as I said, because of the advantage of the time, we don't just have to repeat the previous analysis, but we can actually perform additional analysis that wasn't feasible before. So, for example, we published about 5 or 6 years ago a study in hereditary sensory neuropathy, looking at MRI fat fractions outcome measure. So in the original study publication, we had a single slice across the calf in yellow here, individual muscle segmentations. But the AI allows us to do every single slice in this block, indeed every single slice in the thighs and the calves. We then eliminated ones at the top and bottom that weren't overlapping and analyzed the bit in between. We even did some individual muscle segmentations that were manually done by observers. Now, just looking at some of the data, this allows us, rather than just seeing a single slice at 13 centimeters, we can see the fat fraction across the whole of the calf muscle. And really interestingly, this here is the average fat fraction in patients that did have abnormalities. There isn't very much of a gradient in this condition across the muscles. And again, there's a number of patients, of course, that have normal fat fraction that we would be looking at in the feet for example. But again, we can see now the fat fraction across the entire muscle rather than just a single slice. This is the same graph, but now for the longitudinal change, the scale is completely different. It looks a little bit more wobbly. But again, the original analysis, which is 13 centimeters, so we're effectively analyzing just this little lines here. And so we also looked if we did, say, 5 slices, or if we did the entire block, if that had any effect on the responsiveness. Interestingly, the answer is it didn't affect the responsiveness. The top here is the responsiveness of the outcome measure. Single slice manually done, 1.06. Single slice done with manual automated segmentation, exactly the same. Moving to 5 slices, moving to 31 slices didn't improve the responsiveness at all. And of course, that's because essentially our measure is quite good, and there's really not much change if you do more. So again, really interesting to find that out, and indeed, a relatively simple analysis is as good as a more complicated analysis, which is good to know. Again, we're going to give that a draw in the sense. We're going to give another score to the computer because it could do more in-depth analysis. We've now used the muscle sense to analyze new data sets. We published this earlier this year. This is a subgroup of the ACT-CMT natural history study in CMT1A, for which MRI was one of the main outcome measures used. We've actually analyzed the entire data set, but this is a subset of the Queen Square patients. And essentially what you can see here, again, this was purely done by AI, but we were checking in the yellow if it wasn't quality controlled versus the blue if it was quality controlled, and you can see there's essentially no difference. There were some minor changes made by Luke, who was checking them, but less than 1% of the boxes were changed, and the results were exactly the same. So again, another mark for the computer here because it took 1 minute rather than 25 minutes. Further developments. So again, as you can see at the moment, we're really still concentrating on doing all the muscles together, but we are now able to, Muscle Sense 2.0, I spelled it right this time, I'm not sure why. We can now segment individual muscles. So on the top here, we have the human segmentation across a number of different diseases, and the bottom line is the AI segmentation, and you can see they're essentially exactly the same. So we now have the ability to segment individual muscles, which we'll use going forward. And really excitingly, actually, in terms of what we're talking about with the diagnosis, is that we can use the same software, the same program to segment just T1 weighted images that you would collect as part of your routine clinical scans, the same with stir images. And again, you can see that the muscle segmentation is very accurate. So again, the idea would be that if you did an AI segmentation of a T1 weighted image, you could then feed that into the diagnostic algorithm and come up with the pattern, what the diagnosis is. Future plans, for those people who know about AI, we're looking at an improved neural network foundation model. No response, okay. That's really exciting if you're into AI. But in terms of what we can do, we're going to be doing whole muscle segmentation. And again, currently we're doing whole muscle, but by doing each slice individually, you can make the system even more powerful by allowing it to see across different slices and to work out the muscle memory that way. We're gradually increasing our coverage. So we're having a study at the moment, hand muscles and ALS, the feet and CMT, the bulbar muscles and IBM, and gradually by building up the database, we'll be doing whole body muscle segmentation. Really quite exciting though as well is we've got a project, as I was saying before, we can then integrate that with diagnostic algorithms. What's really exciting is we're looking at a project at the moment to integrate the quantitative sequences into the clinical protocol. So rather than doing a T1 and a stir, we would do a Dixon and a T2 mapping as a clinical scan. And of course, the problem with that currently is that it takes a lot of analysis, whereas if the AI can analyze that and you put it in the same pipeline, you can integrate those quantitative results with the clinical reports. So just to conclude, MRI muscle segmentation with software trained using deep learning neural networks is rapid, accurate, reliable, and results in responsive outcome measures. Larger data sets and improvements in technology will allow whole body muscle segmentation. And again, I should say that there are already commercial companies that are doing this. And again, they don't really publish quite how they do it or how it works, but again, it's definitely possible. And they can probably do it better than human segmenters. and has a major potential role when MRI is used in clinical trials. And again, excitingly as well, if you integrate these techniques with the quantitative techniques with clinical symptoms, that will improve diagnosis and progression monitoring in clinical practice. I just want to briefly acknowledge all the members of the Queen Square Neuromuscular MRI Research Group, in particular Barris Kamba and John Thornton, who are the main people leading in the AI work. All of the MRI study PIs that provided that training set, and in particular, the people who spent countless hours segmenting them so that future clinical fellows don't have to, and also the funders on the right. Thank you.
Are there any questions for Jasper?
Thanks, Jasper. Great talk. I just wonder if you see a world where the segmentation part of this process is taken out and you just go straight from the image to a sort of whole scale analysis without the sort of segmentation and then feeding the algorithm part of the process.
Definitely. So from a diagnostic perspective, the ultimate would be just to feed in. And again, it's a bit like the difference between just machine learning and a neural network. If you kind of direct it to do stage A and stage B, I think the difficulty is there are so many other factors involved, but actually you are limiting yourself by doing segmentation. There may be other features in the image that, as human observers, we're unaware of that it can pick up. So yes, you just need larger data sets, and again, that's definitely the way of the future.
Yeah, thank you very much for the interesting presentation. So you mentioned the foundational model. So there's one foundation model called segmented anything, SAM, from the Meta. I was wondering, Sam, have you ever tried to fine-tune SAM for segmenting muscle?
SAM, sorry?
Yeah, segmented anything, SAM, from Meta. It's a foundational imaging model.
So again, it's probably getting slightly above my pay grade, but my understanding from Barris is that currently before you put in your images of the, in this case, muscle MRI scan, the machine learning is pre-learned on other images. And currently, it's literally just images of random things. It could be dogs, could be cats. So it hasn't kind of learned on scans or MRI scans. And so again, the new foundation model will be using a set of MRI scans at least, and preferably muscle MRI scans, so that before it even starts, it's at a much better level. But I'm not sure what SAM is. You'd have to tell me afterwards.
Beautiful talk, as always. What type of sample size you would need to do this type of analysis for a reliable segmentation? How do you come to numbers?
Well, I have to say I was pleasantly surprised in how few samples are required. And, the original Muscle Sense version 1 was trained, as I said, on 170 scans and did very well even when different diseases other than those that we included in the sample were included. And again, we're kind of at a head start. I mean, one of our research physicists applied the calf algorithm to the forearm, and it did surprisingly well. And so again, when you're expanding it, it probably is only a few extras that you need to teach it on the new thing, and then it all just kind of builds from there. And of course, the other advantage that you have is once you've got the basic algorithm working, you can use that to segment more images, get them quality controlled, and then feed them back in. So it does kind of take off once you have more images. But yeah, as few as a couple of hundred were enough to really train it very well.
Yeah, thank you again.
Thank you.
So I'm happy to introduce Xing Song from the University of Missouri. She will talk about towards better understanding of ALS using a multi-marker discovery approach from a multimodal database.
Yeah, a lot of M's there. So that's why this project is short for ALS4AM. Thanks to Dr. Morrow, did a really nice job giving an overview about artificial intelligence and machine learning being a subset of it and deep learning being a subset of machine learning. So sort of related to that, my approach will be a non-deep learning machine learning approach for doing data mining in a messier database and in order to potentially find useful new knowledges that can better, towards the better understanding of the risk factors for ALS, and also informing a optimal treatment models based on the current real-world settings, what would be the optimal ones towards a better survival among the ALS patients. So this is a funded work by CDC, Agency of Toxic Substance and Disease Registry. We had 3 aims, but then the major motivation out of this that we want to propose this work is because out of the disease-specific world, there has been decades of national collaborative efforts of gathering real-world data and putting them together into a integrated databases, and then try to, and that's, it's usually mainly primarily based on electronic health records, but there are a lot of good information in the electronic health records, and when you pull them all together across multiple institutions, so you can think there are a lot of potential use of that data. And especially after COVID, the barriers of pulling data across these different institutions has been reduced significantly. So there's, so our data sources is actually a multi-center EHR database linked with Medicare claims, because ALS patients are usually get the benefits from Medicare, and a lot of their data is also shown in the Medicare claims. And on top of that, we're able to geocode the patients based on their address history, and been able to add a lot of other additional contextual databases that is usually open sources, like the environmental exposures in their living area, like some socioeconomic variables that are related to their living area. So that's actually one of the motivations. And since this kind of data has been there for a long time and the quality of it kept being improved, it has been used a lot for many common diseases. And and given the accumulation of the data and then the improved quality, we think it might be also a good potential resources to help with rare conditions like ALS or other rare neuromuscular diseases. So we have developed some machine learning-based risk factor discovery models based on other diseases. And then we're thinking this could also be applied for ALS, although we need to do some fine-tuning and adjustment. So there are 3 aims for this project. Aim 1 and 2 is to look at pre-diagnosis phase, and we're trying to discover generalizable real-world evidence on the either confirming giving additional evidence on the existing, about the existing risk factors already being known or partially known for ALS, and also discover potentially new risk factors related to ALS. And aim 2 would be is to explore complex real-world clinical representations that can enable a potentially early risk stratification between ALS patients versus non-ALS patients. And aim 3 is looking at the post-diagnosis phase, what would be the most optimal care model, especially the timing of specialty involvement in the multidisciplinary care that would maximally extend survival for ALS patients. So this is just a quick, little bit more details about the data source that we have. This multi-center EHR data is built based on the PCORNet, which stands for Patient-Centered Research Network Infrastructure, where we do have this shared mission of support multi-center trials and also multi-center observational studies. So, the Greater Britain Collaborative, short for GPC, we're one of the largest PCORNet networks that covering mainly the Midwest institutions, including several sites in Texas and Utah. And we share this EHR, we pull this EHR data together and then link with multi-states Medicare claims so that we can create this longitudinal, more comprehensive data sets for tracking patients over time. And of course, on top of that, because of the availability of the address history information for patients, we're able to link in these different public available social determinants of health databases and environmental determinants of health databases, like toxic release inventories, like pesticide exposures for different areas. So the first experiment, more towards aim 2, we're trying to discover, using these data sets, to discover minimally stable feature set for early separation of ALS versus non-ALS patients. And while we're trying to tackle this problem, we're also trying to tackle an informatics challenge that a lot of the existing feature selection algorithms that are usually machine learning or mainly data-driven are very unstable. So you change a sample, you change a population, everything changed. So we also tried to develop a method called consensus-based feature selection, so that we're able to not only select the predictable feature sets that can best separating the risk, but also stable ones, which shouldn't change when you apply to other data sources. And also we want to get this minimally necessary useful feature sets for the prediction of ALS. So this, since this was done at the very beginning of this funded project, so back then the EHR data wasn't quite integrated in, but then for the second and the third experiments I'm going to share with you, we do have EHR data involved. But for this one, we mainly use the Medicare claims, 7 years Medicare claims, and we identified 2,879 potential ALS patients with at least 2 diagnoses that are documented on 2 separate days. And we require a 2 years enrollment into Medicare prior to their first diagnosis. So we are having this sufficient observational windows for information leading up to their first diagnosis. So, and then for the control group, there will be all the non-ALS patients, but we do a 1-to-5 matching based on sex, race, ethnicity, and age at their enrollment, so that these 2 groups are comparable. And the covariates or features, which is the same word of covariates, just from the machine learning folks that like features better. Our historical comorbidities, more than 500 distinct comorbidities for these group of patients, and also all of their historical medications at the generic level, and which added up to, of course, adding demographics that add up to around 1,300 covariant features. So it's a high-dimensional data, and everyone knows there's this big collinearly relationship among the variables that you can discover from any real-world data sets. And then there's a nonlinear relation with everything. So we developed this machine learning-based, consensus-based feature selection algorithm to identify the minimally useful feature sets that are both predictable and also stable. The core idea is very simple. You create enough variabilities based on your existing data, and you ensemble them together based on agreement across all the findings based on these varied samples that you created. This technique helps us to rapidly reduce the sample, the number of variables from 1,300 to 24 features that are predictive of ALS onset. Not ALS, the first ALS diagnosis, at least based on this cohort. And these are the features being selected. Those are features that are supposed to be both predictive and also stable over different perturbations of your samples, or different techniques. There's some limitation with the analysis. Now we're just based on the comorbidities and generic medications. But we think this method could be expanded when we include more features and the variables into the framework. Well, just with these 24 features, we were able to achieve pretty promising results. This first figure is the accuracy of identifying, separating ALS from any other non-ALS Medicare beneficiaries. It does achieve a high accuracy, and then the x-axis are month before the ALS diagnosis. So the first data point will be 3 months ahead prediction of the first ALS diagnosis, all the way to the very right point will be 18 months ahead prediction of first ALS diagnosis. And of course, it's reasonable because there may be a lot of, we're comparing ALS with many other healthier Medicare beneficiaries. So that we did a step further to look at how the model, but just based on these 24 features, would separating ALS from other non-ALS patients, but with some bulbar onset symptoms. And then it's still achieving decent prediction even 18 months ahead of time with an accuracy around 75%. And then we do the same to see how the model is separating between ALS and non-ALS patients with some limb symptoms. And it's still, I think that the performance is achieving a decent performance. And then this is the one with applying to separating ALS patients with those with bulbar and limb onsets. So I think it's promising in terms of only with the historical medication comorbidities we can achieve this kind of good separation between ALS and non-ALS patients, even with similar symptoms. Even if we can add more variables to it, there could be good potentials of creating a nice prediction models for separating, for identifying early detection of ALS potentially. So there's, of course, there are a lot of other things. There are a lot of limitations with the current analysis. We need to add in more variables. We need to do more sensitive analysis to show the robustness of the results. But I think there's some promises over there. The other experiment that we do is more focusing on exploring environmental risk factors. And then we're leveraging some causal inference methods together with machine learning to do that investigation. So given that the environmental exposure data are usually at area level, so at the starting point, instead of actually decomposing the environmental exposure data to individual level is a non-trivial work. So we're still working on that. As the first step for the experiment, we actually developed a ecological model aggregating the ALS prevalence rates at county level and try to associate those different environmental risk factors to the prevalence rate and to see which one is more highly correlated with the high prevalence rates of the ALS. So the environmental exposure database that we're mainly using for this experiment are the toxic release inventory, which include more than 500 toxic chemicals that are supposed to be reported by EPA on an annual basis for different geographical areas. So we leverage that. And we also include the agriculture pesticide use estimates, which is also a mandatory report by EPA that's supposed to tell about the different types of pesticides exposures at different geographical area. So there are more than 400 different types of pesticides exposures being reported on the area level. So we started with almost 5,000 different environmental exposures. Of course, we applied our consensus-based feature selection, and then we applied a causal machine learning technique. So we're going a step further than just looking for the association, but looking for potential causes of potential environmental causes that could explain the high ALS prevalence rates for the particular area. So after applying our consensus-based feature selection, we reduced the potential environmental risk factors from 5,000 down to 114. And then after we apply this causal machine learning technique, which is also called deep-biased machine learning, we actually go down to this 7 potential environmental risk factors that are highly associated or potentially causally associated with high ALS prevalence rates. We're really happy to see LAD over there because that's an established neurotoxics that has been shown the association with the ALS. Beside that, magnesium also been found that highly correlated with high ALS prevalence rates. But among the 7s, 3 we found some of the existing literatures showing they are neurotoxic, but we also were surprised to find 4 that we couldn't find any evidences of showing they're neurotoxics, but then based on our data, it is showing high potential causal association with high ALS prevalence rates. There are 2 fungicides. Forgive my pronunciation, so I'm still trying to learn all of these complex words. Metalaxyl, and the other one is carbixin. Those are 2 different fungicides. And also the other 2 chemicals showing high correlation without existing evidence are barium and then sodium nitrites. So I think we're thinking about doing further validations and then to really see, working with the geospatial analysts and and to see whether these are something worth further investigation on. So the third experiment, more towards AIM-3, we're looking at the post-diagnosis phase. And we're also trying to leverage the causal machine learning model to really decompose the survival benefits out of the multidisciplinary care based on the real-world care setting. So everyone knows what multidisciplinary care is. I'm going to skip these slides. We're using the crosswalk population, which is the population where we have both their EHR data and also their Medicare claims. So we're guaranteed to have a relatively comprehensive data sets for this patient cohort. And then this time, we also learned about a more advanced computational phenotype for identify confirmed ALS patients out of like a big database. So this is something that CDC actually is using for their ALS disease registry called CDC capture recapture algorithm, which is not just based on diagnosis code, which what we did at the very beginning. It's based on a constellation of facts related to either treatment for ALS or visits to neurologists, multiple visits to neurologists, or the fact that if someone is Medicare eligible under the age of 65 years old and with multiple diagnoses of ALS, they're highly likely they're eligible because they have ALS. So a variety of these facts putting together, and we're able to identify 5,198 confirmed ALS cases. And then for them, we tried to look at what happened after they received their first ALS diagnoses. What are the specialties they see? What are the different diagnosis codes that they get? And what are the different medication they are using along the way? And then try to see what will be the timing of the specialties involvement that they can maximally extend the survival. So the second column here is the demographic breakdown of this, I call this linked population because I have data coming from linked across different sources. And it's primarily white and 6.3% Hispanic. 34% are eligible for low-income subsidy or dual eligibility, which is usually used as a proxy, so reflecting someone's socioeconomic status. And also, since we also integrated the data from the social determinants of health databases, so we're able to also see whether they're living in a relatively rural area or urban area. So this is just another, while you try to tackling the clinical challenge, you're also tackling the informatics challenge, which I found is the beauty of doing this kind of work. So the longitudinal nature of EHR data actually holds a lot of good information, but the utilization of it is quite limited. So actually toward that, we're developed a marginal structure modeling technique that can account for time-varying covariates, time-varying exposures, and time-varying confounders. I'm going to leave the technical details aside. If you're interested, I'd like to talk more. But basically, using this model, we're able to decompose the survival effects at different time points for different providers. So if you just focus on the red lines, which is the adjusted model, the green lines was put here, that's the unadjusted model to show how they're different. The red lines are after the adjustment. What we found is the three circle one, neurologist, physical therapist, and speech language pathologist. You see this little uptrending curve of the red ones that is showing if they're involved at the very beginning of the care, in our case, when they first get their diagnosis, the survival benefits for the patient is maximized. The later they got involved, the survival benefit can diminish over time. Okay. Okay. Yeah, I'm close to the end. So ongoing work is right now we're developing this whole model using our the PICORnet-based EHR Medicare linked database, but we're hoping to do further validations using a total different databases. We have already established our collaboration with DoD VA. They have their Da Vinci databases, kind of resembled what we have gathered together. And we're trying to replicate this work on their database as well to show if we see consistencies or if the multidisciplinary care models vary between these two kind of organizations and what can be learned from each other. So yeah, and then thanks for all of the collaborators on this and especially CDC for sponsoring work. Thank you.
Thank you, Xing. Very exciting work. We have time for one question. You can.
It's great. And I've been trying to tell my neuromuscular colleagues more about PCORI and PCORI-NET. And as we talked the other day, a lot of specialists just don't know that this database exists. And yours is more than, you've got all this Medicare data in there too, and EHR. So this is just the Greater Plains Collaborative. So you didn't have on your next steps, how can you do this same analysis so that you can have all the PCORI network data, which is about 100 million people, and so that you can refine it even more. And by the way, we had that little brainstorming thing about a myasthenia gravis project. Everyone in that room is in a PCORI-NET. We looked up, and so you may not know you're in a PCORI-NET, but you probably are.
And every site has a dedicated informatics team that actually are gathering all of this EHR together and transform into something we call common data models. To your question, Dr. Barron, to transfer my work to all the other PCORI-NET sites can be immediate, because all of our data already being transformed into a interoperable format. Well, administrative asides, technically speaking, yes, the transferability of this work to all the other PCORI-NET sites can be immediate because we all have the exactly same data format. You just put the model on that format, and it will run and get the results.
Because you really showed two different sets of data, sort of. Maybe you did show combined. It looked like there was more synthesis you can do with your data.
Yes, Medicare, Medicaid, or Center for Medicare and Medicaid, they have been providing their data for research purposes for quite a bit. And they have gathered their data, and then they also support linkage. As long as you have some kind of identifiers in your database, like Social Security number or Medicare beneficiary identifiers, or a sequence of identifiers. They're working with ResDAC, which is at University of Minnesota. They're the data analytical center. They can link the two things together using that overlapping identifiers. So in our case, it's already been linked.
Thank you.
Thank you.
And now our final speaker of the final session. And this is Jiangling Cheng, also from the University of Missouri, who will talk about AI methods for integrating multi-omics data and inferring gene regulator networks. Complex titles in this session.
Thank you very much for the introduction, and also thank you all for staying till the end of the meeting. Today I'm going to talk about how to use AI to solve a major problem many of us are facing, integrating omics data to generate the biomedical knowledge. So nowadays, biomedical scientists routinely use high-throughput sequencing technology to generate the multi-omics data, like use whole genome sequencing to generate the genetics variants of the patient, using RNA-seq to generate the gene expression data, and using mass spectrometry to quantify all the proteins in the human cells. Now, the challenge is, how can we integrate all this data together to obtain biomedical knowledge about the patients? And it's very important to integrate them because each data source captures the different aspects of a biological system. So integrating them gives us much better understanding about the biological systems. However, it's difficult to do so. The first is different data sources have different data types. They're heterogeneous. It's not easy to compare them directly. Another is the data samples tend to have very high dimension. So you measure gene expression of thousands of genes, but you only have a few small number of samples. It's very hard to do so. But if we can address this problem, then we get a lot of benefits out of it. For instance, we can understand the disease mechanism, we can apply this to study personalized medicine, prescribe the treatments for the individuals, and also we can use this to design drugs. Traditionally, scientists use different approaches to do so. Firstly is manually integrate data. So you search in literature, you do some differential expression analysis, but it's very time consuming and it's very hard to identify subtle relationships in those data. Another is you can use statistical approach to calculate the correlation between the data, but these can find some associations, but cannot identify the causal relationship, which gene drive this disease, like what Xin talked about, causal inference. Another is you can use regression, but the regression methods are not very good at dealing with high-dimensional nonlinear data. So we need to use artificial intelligence technology. So artificial intelligence technology can handle very complex data, discover nonlinear relationship, and also they have very strong predictive power. As Jasper mentioned earlier, you can predict the phenotypes by integrating different data sources. You also can discover causal relationships between genes and the disease. And finally, machine learning can be automated. You can automatically learn from data, reduce the need of manual intervention. Now, I'm going to use one example, collaboration example, to illustrate how to use AI to extract knowledge from multi-omics data. So this is a collaboration work with Joy. So both of us work at the NextGen building. It's a brand new building at our campus. So that makes us have a chance to collaborate with each other. She's a reproduction biologist. She actually used omics data to study the biological process in the female mice reproduction system. So she's interested in investigating biological mechanisms involving the oviductal response during the lateral fertilization in mice. Basically, oviduct is a tiny organ in the mice reproduction system. Its function is to transport the fertilized eggs from ovary to the utero. So she tried to understand after the mating, of the mice mating, how this process, what molecular process make this happen. So she basically gets the natural mice, male and female mice that mated, basically get pregnant. Then you try to imagine the two regions of the oviduct, IA region or IO region. She used the RNA-seq data to measure the gene expression at the control at 1.5 days after the pregnancy, 1.5 days, and 2.5 after the pregnancy. She also used the complementary techniques, mass spectrometry, to measure the protein expression at all those 4 time points. Now, the problem is she got a lot of nice data, but she and her postdoc couldn't figure out how to make sense out of it. How to discover the biological mechanisms? What are driver genes? What are the key transcription factors? What knowledge can we get out of it? So that's why she approached me. So, hey, Jack, could you help us to do some analysis about it? I said, I never did this, but I can give it a try. So my intuition is that traditional statistical approaches won't work for this one. So we need to use artificial intelligence. But in order to use artificial intelligence, you need to define a prediction problem. What do you try to predict? What's the input? What's the output? Right? Here, we don't have many labeled data. We don't have labeled data. How can we formulate this problem? So, but we know protein expression depends on gene expression. So we can use protein expression to predict the gene expression. So our input would be the expression of genes in each samples in IA region, IO regions. Each will have 3 replicates, that's 6 numbers. And also have another input is whether or not this gene is a transcription factor. So we use this, try to predict the abundance of the corresponding protein in the proteomics data. Abundance means we classify protein into two groups. One is if the expression level is higher than a threshold, let's say 0.8, is abundant, otherwise not abundant. So our goal is to use gene expression data as input to predict the protein expression. If we can predict this very accurately, then we can identify key genes that regulate the protein expression. That's our goal. So we give it a try. So that's the concept. Now the next thing is, what a model should we use to get most out of it? So the machine learning model we choose is transformer. So it's basically a similar model to the large language models like ChatGPT. So basically we try to translate the gene expression to protein abundance information through this model. Why did we choose this model? Because it has two key techniques that we need to solve this problem. The first is called a self-attention mechanisms used by the transformer. The idea is this technique can identify the key features in input that determine your output prediction. Just here I use one example to illustrate this idea, translation. So you translate in natural language processing, you translate the Spanish sentence to English, right? So we generate each word. Then we generate the first word, we check which Spanish words are most important. We pay more attention to it. That's highlighted in the light color. Then we generate the next word, we find out which Spanish was more important to generate this word. We continue so. So basically we can identify which words are more important to generate my output. Same thing applied to when I predict the protein expression for the gene expression. I can use attention to identify which genes are more important for predict the protein expression abundance. Another key technology in transformer is called self-supervised mask learning technology. This is very important. Remember that Joy only has 4 samples, control, 0.5, 1.5, and 2.5. We cannot use 4 samples to train a machine learning model with millions of parameters, thousands of parameters, right? What can we do? Fortunately, we have very smart technology in natural language processing. Do you know how the ChatGPT was trained or large language model was trained? Basically, you give an input sentence, you mask some words, you try to predict the missing words. That's just that simple. Or predict the next word you're going to say. So here idea is, give a sample of the gene expression, 16,000 gene expression values. We randomly pick some of them and mask them out, set them unknown. Then we also set some their corresponding protein expression unknown. Our goal is to use this masked gene expression input to predict the protein expression. Because this process is random, I can use one sample to generate many, many samples. So that's a key innovation. Then I can train my machine learning model. So here is our input, original input. You see, I have input RNA-seq data, I have output is proteomics abundance data, I only have 4 samples. But using masking technology, we actually generate hundreds of the examples, 161 per samples, 560. We can generate many more. So this actually turned out is sufficient. So we use about 100 per sample for training, 20 for validation, and another 20 for testing. Then after training and testing this model, then we blindly test on the withhold data at 2.5 DPC days. Now, how accurately can we predict that? Then here's the results of the predicted protein abundancy. You can see if I set a threshold at 0.8 to determine whether or not abundancy or not abundancy, you can see we have 0.91 accuracy. And we also have high precision, high recall, and also high F1 score. If you change the threshold, you get still pretty good results. This actually is very significant because now we can accurately predict the protein abundance from RNA-seq data now. That means if you only have RNA-seq data, I can predict the protein expression information for you without doing the mass spectrometry experiments. But this is not sufficient. We still didn't get the biological knowledge yet, right? What are the driver genes? Then we did this analysis, use attention. So because we already mentioned that, we can generate the attention between all the gene against genes. For each protein, we can see which genes have high attentions, right? But we don't want to study all the genes, so we actually only select the genes and the proteins that are differentially expressed. Then we identify the transcription factors genes that have higher attention scores for those abundant proteins. So we identify 25 of them. So here are the key transcription factors we identify for each time point. So those actually have high attention scores likely regulating determining the protein expression. so they can be used for experimental experiments. Then we check them against reactome and gene ontology to identify their function. That's the most interesting things coming out. So based on their function, we found that after mating, at 0.5 dBc, a pro-inflammatory condition is initiated, biological process. Then after that, at 1.5, actually, genesis and the cellular stress maintenance started. So you can see the cells automatically change its regulation, goes through different biological process. Finally, at the 2.5, we see the senior and the cellular homeostasis process was started. So, and this actually match with in vivo observations of the genetic markers. So basically, from those gigabytes of data, a lot of gigabytes of data, we cannot make any sense at the beginning. Now we generate the identified transcript factors for the experimental test. We also reveal possible biological mechanisms for explaining this biological process, explaining the function of the oviduct. And this approach can be applied to study any disease, including the muscle disease of this meeting focus. Here's my conclusion. The first is AI is a powerful approach of integrating omics data to discover biological knowledge. The second is self-attention is very useful for identifying key genes, proteins that drive the biological process. And finally, very importantly, if self-supervised mask learning, this populated in the large language models, is so useful for training AI methods with very limited number of the biological samples. So, and with that, I'd like to thank my PhD student, Akshata, my collaborator, Joy, and her postdoc who are doing this work, and also funding agency for supporting this research. And thank you very much for your attention. Yes.
Sorry, that's a very tough presentation for a neurologist to understand. You know, before the quantum mechanics, physics was very deterministic, whether it was the special or general theory of relativity or the mechanics of Newton. But after that, the science of probabilities was opened by the quantum theory, and there's no end to the possible probabilities to anything you do. What are you using as a model for your artificial intelligence model? Are you using the quantum computational model or the classical binary model, which is very limited? Do you think entering the quantum mechanics as a model would explode the artificial intelligence for the new generation of computers?
Yeah, I think that's a great question. So yeah, I'm glad that you mentioned the quantum models, physical models, yeah, those classical models. Here, machine learning models are the data-driven models. The data-driven, the automatic identify patterns, statistical models. However, the new trend is how can you integrate those physical knowledge-based models with the data-driven models? Use them as a prior knowledge to design your models to get even better results. So yeah, for instance, potentially here, if we have biological knowledge, we can encode them into our model. So you're right. So this kind of model, artificial intelligence model, are the data-driven, but we should integrate them with knowledge-based, quantum physics-based models. That's one goal. Another goal is, even use data-driven model, we still need to identify knowledge, right? Understand how system works. So that still goes back to the original mechanisms, physics-based approach. Yeah.
Okay, then we conclude this final session.
May I ask the presenters to come, please? 4 of you, would you please come here to the front? I hope you are all here still. Oh, who is that? Oh, okay, okay. So this is Dr. Assad, Dr. Masi, Dr. Agradi, and Dr. Zara. Okay.
And any of the sharks is here? I know Amanda. Yeah, send it. Let's please come over. Gordon. I know that Amanda had to go to the airport. Yeah. James. So the sharks have met and looked very positively. Here's another shark coming. Here we go. Yeah. They were very impressed by your presentations, and you all had made excellent points, and all your projects will help us understand these topics better. But you all know that there's a scoring system, and the top two were very close, neck to neck. So I had to talk to Rick to get his approval to see if we could grant the top two $10,000 each. And the second two, because also they were very close, they were very great, they would benefit from some constructive criticism and for meeting with experts in the area. So we decided to give them free consultation with two experts virtually between now and the next meeting. And hopefully they can work on their projects and present them. So all of your projects were excellent, and thank you very much. So the two projects that got the highest points are, number one, the MRI as a biomarker in periodic paralysis. Congratulations. And the second one is the MuSK is a mucosal trigger responsible for MuSK, Dr. Massey. Now, Dr. Agardi and Dr. Zara got very good scores, and we thought that their ideas were very novel, and we will extend to them a meeting with the experts to have more, to work more on their presentations. But thank you very much. That was a great presentation. Thank you. That concludes the shark session for this year, and probably this is my last time I lead this forum. We want to pass this to the new leaders, and I talked with Rick. And thank you very much for attending and for your participation, and hopefully to see you next year. All right, thank you very much. Thank you. Thank you very much. Yeah, thank you very much. Thank you. Okay.
We'll see you all next year in Italy. Yes.